Here's your hydration.
You're good to go there? You got some water? Let me know when you need a bathroom break. All right. Everybody ready? All right, this meeting's called to order. Good morning and welcome. This is our March PEB board meeting. Meetings this year are going to continue to be hybrid. Healthcare authority staff will be on site when possible. Board members and other attendees have the option of attending on site or via Zoom. For our Zoom attendees, our opening slide is information on how attendees can turn on closed captioning subtitles. And we're also going to explain the new technology here to everyone, so that will be cool. Let's do a roll call of board members. Elliot.
Here.
Okay, now that we're going to do that, there's a little button you push right in the front.
Present.
There you go. And then see how our names light up and everything? You can tell who's on there. It's pretty sophisticated stuff we got going here. Sharon.
I'm here.
Harry. Michaela.
Here.
John. Here. Kurt.
Here.
And Tom.
Here.
And we have Michael Tinnick from the AG's office here. Excellent. And I'm Lou McDermott. I'm filling in for Sue Birch today, and I'm the deputy here at HCA. While board members attending both in person and virtually, it would be helpful for the board to hold their questions until each presentation is done or when the presenter pauses and asks for questions. Board members attending virtually, we're also going to watch in case you use your Zoom hand. If you're in the room, use your real hand. There's lots of resolutions being introduced today, but none are scheduled for action today. The public is going to be able to provide general comments at the end of the at the end of the meeting during the public comment period. And as a reminder, if the public has questions during staff presentations, the presenter's contact information is included at the end of their presentation, and the public is welcome to email presenters during the meeting, capture your questions for response after the meeting. And Dave's going to give us an overview of today's agenda and the technology.
Yes, good morning, Chair McDermott, members of the board. We do have some new IT since the retreat. You'll remember, for board members, past couple of years, we had a different system. We now won't have wires to trip over. That's one of the big advancements with this little system here. And it just helps us project better, get a better audio recording. And in the long term, it's a short-term investment that saves contracting dollars long-term. So yay, efficiency in government. So just wanted to highlight that. But yes, turn your mics on and off. And conversely, red means stop when it's in the ceiling, but it means go when it's on the mic in front of you. So we're live because green
wrap our heads around that.
We know that red in front of us means that now we're talking. So it's just, but your mic is on if you see a little red ring around your microphone in front of you. And the audio for the room is in the ceiling, and we know that it's on if it's green. So just fun with color codes.
And you also get to see on your display whose mic is on. It'll show who's speaking, which I can see in a big room with tons of people that you're not 100% familiar with. That'd be awesome.
Yes, so very, very excited about that quick advancement. So today, as Chairman said, we have a lot of resolutions to introduce to you. I think last time I counted, it's 22, 23, a wide range of pieces. I like to describe that this part of the year in our cycle, we have a lot of eligibility and enrollment rulemaking that needs to happen. And in order to get that to happen on its cadence for rules to be in effect by the next plan year, we have to have the board take its actions related to that policy development in April, which means we introduce them in March because we have a strong tradition of introducing in advance of a meeting in advance of a requested vote. We also have a lot of work that we brought to the board about the potential to change the Uniform Medical Classic Medicare plan to from accreditable drug coverage to a Part D prescription drug benefit. And we have a variety of resolutions related to that. And we also are in the midst of implementing the legislative decision to move to a standalone vision benefit for our non-Medicare population and our employees. And so we have some resolutions to establish that benefit structure and some of the eligibility and enrollment rules. So lots of moving parts here, and all of them have policy resolutions. I think you get to hear from Stella in 3 or 4 times today. So she will be your new best friend during this meeting. She'll be, Ellen's your best friend because she's been here for every, I don't know, it's a PEB board meeting. We don't have an Ellen presentation, but your second best friend for this meeting is Stella. So we'll start off just talking a little bit of a wrap up on the legislative session. Kate will talk about bills that passed. Some of them have been acted on by the governor, some have not. We'll have Tanya come back at the April board meeting to talk about the budget after we don't have any significant concerns about the general nature of the budget revision, but Tanya will go over that meeting. We have some follow-up presentations on behavioral health. We're going to talk about pharmacy consolidation that's been happening in the market. A lot of people have heard about a lot of closures. We talk about some of the impacts that are happening with our portfolio, about the network. And then we'll have our first Stella presentation working through dual enrollment prohibition refinements. We'll move into the vision benefit that I was just describing, have a update on smart health because we switched vendors January of this year. We had hoped to do that at the retreat because of that big switch, but we needed to make some space at the retreat agenda, and so we moved Kristen to this meeting. Before we go into the Medicare Part 2 conversation, Luke's going to talk about the Inflation Reduction Act, some of the things that are related to our Medicare space and impacts from the IRA. Then we will spend a significant part of the afternoon talking about additional follow-up on the Medicare plan option for UMP Classic. And then we will have an executive session to kick off our rate setting process. So that's what we have today. Two other reminders: if we have an emergency, we run across this or walk or run across the street to the visitor parking lot that I'm pointing to my left. And if you need a restroom, it's down the hall to the right. If you see elevators, look to your left.
Any questions for Dave? I think we can walk to the parking lot. I don't think.
I guess it depends on the emergency.
And folks, this is gonna be a long meeting, so if you gotta stand and stretch your legs, or you gotta get a bite or a drink, or go to the restroom, just feel free. But we're gonna take some breaks. We have some breaks scheduled, but if you gotta do your thing, do your thing. All right, we ready to get going? First up, we're gonna be voting on two sets of meeting minutes. One set's from our last board meeting of the 2023 season, and the second set is from our February 1 retreat. Meeting minutes are behind tab number 3. Are there any comments from the board? We're gonna vote on the July 19th, 2023 meeting minutes. Seeing none, do I have a motion to approve the minutes as written?
So moved.
Thank you, Elliot. Is there a second?
Second.
Thank you, Mikala. All in favor, say aye.
Aye.
Any opposed? All right, the July 19th, 2023 minutes are approved as written. Next up is the February 1, 2024 retreat meeting minutes. Any comments from the board? Seeing none, do I have a motion to approve the minutes as written? Thank you, Harry. Is there a second?
Second.
We've got Elliot and we have Kurt. Was it Kurt or Tom? Okay, so we've got 2 seconds and a third. All in favor, say aye.
Aye.
Anyone opposed? Hearing none, the February 1, 2024 retreat minutes are approved as written. Thank you. And Dave, you're gonna give us a follow-up on the retreat?
Yes, I have one retreat follow-up and then just a miscellaneous update. And so I usually kind of clean up at the beginning of the meeting if there's not something that's sprinkled elsewhere in the agenda. I wanted to talk a little bit about Benefits 24/7. That's our online enrollment system that launched on January 16th. We had a presentation at the retreat talking about how that launch was going, and we've had quite a bit of updates since then that I wanted to talk through. Most importantly, I wanted to be as transparent as possible with the board. Before the 2 board retreats, the sub-board had its retreat the week before PEB and last week it had its sub-board meeting. In the initial kind of 2 weeks of Benefits 24/7, we had really minimal issues that were coming to light. You know, every IT project will have things that just no matter how much you plan, there will be things that you need to resolve. But we had relatively small things and a small number of things. But after the retreats, we started to discover some more systemic pieces that needed addressing. And so I wanted to make sure to bring that some information about that to the board so that members of the public who saw us do a presentation didn't think we were trying to hide the nature of things. In fact, it was the discovery of things since those board meetings, the board retreats that really gave us a lot of work in our stabilization period. So, you know, I thought I would highlight a couple of them. One of the more systemic issues that came to light was that benefit administrators were unable to terminate accounts. So as people go in and out of eligibility, you have to turn off their account, and then that changes the effective date, or the effective date of that termination is first of the next month. But there was an inability for a period of time for benefit administrators to be able to actually key in that into the system. And so we were getting a lot of concerns as they were starting to not be able to key that. It wasn't actually impacting people's benefits yet, because benefits administrators were trying to key things in late January for effective dates of February 1st, or at the beginning of February for effective dates of March 1st. They just couldn't get that into the system. And then to make it even more complicated, even our own benefits administrators here at the Healthcare Authority, their own privileges were curtailed, so they couldn't solve that problem either. Our IT team had to do a patch to make sure that everybody had access to the system. But that was one very systemic problem that came to light as we were going through the process, and began working on that. There are a lot of individual issues, and we actually had a semi-prominent payroll file issue that we had to work through and work with state HR about it. We discovered that in some of the instances where we migrated data over from the old system, we were getting into a scenario where the system was recognizing the original agency, not the current agency for an individual, and was kind of retro terming and reinstating their account to their old agency. So to plain talk that, our CFO right now, Megan Atkinson, is at the Healthcare Authority. Previously, she was at the Department of Transportation. Our file was starting to make it look like Megan was still at the Department of Transportation and charging all the premiums to her DOT account instead of her Healthcare Authority account. The good news is we caught it before most of the payroll files were it was getting more systemic in the payroll files. We had about 100 to 150 accounts throughout the system, out of about 300,000 accounts between PEB and SEB that we noticed that this issue was occurring with. We started to project what it would look like in future months, and we've gotten ahead of that issue. It would have gotten each month, it would have successively gotten a bigger and bigger problem. So we caught it in time for it to not become a mammoth problem. But it was, and there's some cleanup that still has to happen even within those individual accounts. I really want to say kind of publicly that I appreciate state HR working with us, the payroll offices in particular, and state agencies and higher education institutions. When we discovered it, we found a way that would kind of mitigate the impact, but we had a 48-hour window and it required payroll officers to manually do things in accounts at the home agency or home employer. And so there was a lot of kind of leaning in to try to solve those types of things before it got bigger. So those are a couple examples. There are also some individual pieces that, may impact a couple of accounts, a dozen accounts here or 24 accounts here. The important thing for us is every account matters, and eligibility and enrollment things are extremely important and can get prioritized among the ticketing system that we use to kind of adjudicate and understand and track issues that are happening. We also, as an agency, our general philosophy is assume something is systemic until you can prove otherwise. So we always treat issues as, I always say, the canary in the coal mine, for that illusion of, is it something that is really systemic? And we kind of adjudicate it that way until we can prove otherwise. So we are still working through stabilization on individual issues. We think we've solved the vast majority of any systemic things, that the payroll piece that I was describing, the ability to terminate accounts that I was describing, those things came to light since the board retreat. We've worked through those. We're still stabilizing other aspects of the system. That is totally normal in this type of change. I see Michaela nodding. There's a lot of IT projects happening in her neck of the woods too. So we're not trying to hide anything related to the work that's going on. Just wanted to highlight that, first 2 weeks were awesome. And then the 2 weeks after the retreats was a little bit rougher. And the
Less awesome.
Was less awesome. And the 6 weeks after those 2 weeks was a lot of work. We're still stabilizing things. And, unfortunately, we had anticipated launching some additional enhancements for our retirees in the system by the end of this month. That had to get delayed until later in the year because we need to focus on things like the immediate payroll and the ability to terminate accounts. So we had hoped that we would have the next iteration on some of the retiree aspects now, essentially. We are going to keep working on that for later in this year. But we needed to prioritize stabilization and some of the things that came to light after the first 2 awesome weeks. So just wanted to highlight a little bit there and pause for questions on that before I do one other general update. John?
At the university, this was an issue. Oh, sorry about that.
You're okay.
At the university, this was an issue. We had a lot of retirees who were leaving employment and retiring, couldn't get access to their health benefits. Is that all resolved now?
Yes, and with the University of Washington in particular, we also opened up some read access privileges to the old system so that they could continue to be able to adjudicate things. The University of Washington is our largest employer between the PEB and SEB programs. And so we did a little bit of extra work with them. Another good feature about UW is they have a special file integration with our system, and it actually was helpful in that it prevented the payroll issues that were happening in that other, the 100 to 150 accounts that I described. It prevented that from reaching into the UW system. So that was a protective measure, but those things haven't.
Did you have to hire additional employees to do this? Or you did it with the current staff?
We did it with the current staff, Bob and Weave and Bob and Weave.
Yeah, and I just wanted to echo Dave's comments, it's sometimes difficult to get an agency's attention, especially when it's just affecting a few people. But when it affects someone's payroll, it can affect their lives significantly. So everyone did a really nice job, state HR, everyone sort of came together, dug through the files, figured out which ones were messed up and fixed them manually. It was all a manual fix. So really do appreciate the work because, you don't want your paycheck screwed up.
Just for the record, most of the work was done by statewide accounting, so.
Yeah.
We have the relationship, so Brian asked me to reach out, which allowed us to make the connection, which just kind of shows like the need to partner, but statewide accounting and our IT team within OFM were kind of the main players there.
I'll let OFM know that you took full credit for this.
And I have to give a own public personal shout out to our own accounting department here at the Healthcare Authority. We have an accounting manager, Rita, who identified the issue within our own Healthcare Authority teams. And it just shows the power of important critical thinking. She was just kind of doing manual, typical, hopefully standard payroll auditing processes, and was like, why does that person have 40 adjustments in 1 month? Like the high water mark's usually 7 or 8, and then that started us on the path. And so just want to, kind of acknowledge our own accounting team and Rita Holman in particular here at the agency for helping identify this before it became something wider and more problematic for everybody. That's benefits 24/7. The second piece, which isn't related to the retreat, but it is something that a lot of people have been asking about lately, understandably, is the prominence and frequency of provider network termination notices that are going out to members. It's something that, especially, I'll just say in post-COVID times, in the last 2-3 years, there's been many more prominent network disruption disputes that have spilled into the public domain. I think we've had, by my mark, at least 6. So don't ask me to name them because I'm not sure that I would get all of it right. Everybody counts differently, but there's been quite a few. Before the pandemic, it was pretty rare for a termination notice to go out. One of the challenges is the vast majority of times, those notices have to go out under a certain timing schedule by regulations and state law and then regulations implemented by the Insurance Commissioner's Office for the entire commercial market. And there are parts of our portfolio that are expressly subject to OIC's requirements. And so network disruptions are specifically regulated. And there has to be a certain amount of notice from potential termination to the membership within that plan. The vast majority of times, though, the time between that notification going out and the drop dead date for when a termination would actually happen, there is still negotiations happening between the parties, and the vast majority of time they actually come to a resolution, and then that termination is rescinded. Before the last couple of years, most of the time, everyone really tried to avoid those notices going out. As financial pressures have hit different entities in different ways. There are just different strategies and motivations and tactics when it comes to negotiations, and no one side is to blame for it. In any given negotiation, there might be an advantage to either side for the citizens to understand and be mobilized to express the importance of a particular provider within a network. So we're seeing more and more of those. The member only experiences it once. They live generally in the same part of the state. They're, ingrained within a specific provider community, and they don't realize that this is unfortunately becoming a more and more common occurrence, and that it usually works out in the end. So we try to reassure people about what the Healthcare Authority is doing in these instances, and I thought I would describe a little bit more of that here. So when those notices go out, Sue or I, and sometimes Lou, will always be in contact with regions. Usually we're focused on the Uniform Medical Plan in this instance. And one of the main things that the state contracts and pays Regents to do is the provider networking. So we have some specific performance guarantees around how the provider contracting works out. So we're very heavily interested and invested as to what happens in the provider negotiation. But we aren't a direct party to them. And so we will monitor with Regents, sometimes with both the provider network reach out, or we'll reach out to the provider network that's in the middle of this dispute as well, and help kind of understand understand the negotiation from each side's standpoint. A lot of times, the parties are still actively at the table, and we won't insert ourselves if good conversations are continuing. But if there seems to be some breakdown, or we start to hear that both sides think the other side has the ball, and so thus nobody thinks they're up on deck, we will start to insert ourselves in a kind of a shuttle diplomacy mediation kind of style to help make sure that things don't break down for unintended reasons. Just the fact that people think the other side's on the ball. So we work actively in those ways to help make sure that that hopefully there is ultimately an agreement between the parties.
David, I think Elliot has a question.
Sure.
Just for clarification, because this has come up before, sometimes members don't realize that HCA does not dictate the terms of the agreement and can't ultimately force the parties to agree. And I think that's obvious to some people, but in my experience, it's not obvious to all people. And they wind up calling HCA, telling them to fix this.
It's a
Can you
good
comment?
Yeah, no, it's a good point, Elliot, that what we're talking about fundamentally, it is a contractual negotiation, and no one can force two people, two entities to sign a contract. If one side does not want to sign, no one can force them to sign a contract. It's kind of a foundational principle in contracting. And so, neither the Health Care Authority nor the state of Washington can require a specific provider in the Uniform Medical Plan Network, for example. And so we are trying to help understand, and get the parties to a place where they can agree to sign, but neither us nor Regents nor the legislature can bind and force a specific contractual relationship or contractual outcome. Everyone can motivate it or dangle carrots or hold out sticks, but sticks probably not so much. I'm gonna get out of that answer.
Yeah.
But there's no way to actually force anybody to sign a contract.
What's interesting is that you have all these competing forces. You have our purchasing power, our size. There's a relationship piece. Sometimes we have closer relationships with certain providers. We're asking Regents to go out there and do the best they can for our members, but at the same time, is the best you can means that you don't have a hospital in your network. That's a problem. So it's very delicate. It's always delicate, and it's always a little different. And so there is just no one way it gets done. But at the end of the day, we're in lockstep with Regents. They provide us information. We know what's going on. Sometimes we intervene more, sometimes we intervene less, but it's very fluid.
And I really wanted to bring this up because the last month, at the beginning of the year, the big network negotiation termination that was floating out that ultimately was resolved was multi-care. And so that would have had a real, you saw correspondence in your packet concerned about that. And before that, there have been multiple of these that you've experienced in your correspondence. I just wanted to kind of address that. The current one that's on the table is Legacy in Southwest Washington and over the border in Oregon. And so unfortunately, it's seeming like every quarter there is one larger aspect of this. I'll just also highlight the last question that often comes up is, well, when is the Healthcare Authority going to reach out and directly interact with members and tell them about this? We have to balance a lot of different things. One is if we start advertising, we could end up destabilizing positive negotiations that are going on. So we typically will wait unless and until we get to it much closer to an actual termination date to start talking with members about the impacts. I do think that last year Stella highlighted in making, we did make a change in our rules that would allow the agency to initiate a special open enrollment in the event that there is a large provider disruption. We never actually formalized that tool in the past, but with the frequency of those coming up, we at least have that tool. And just wanted to remind the board that if there was a big provider disruption that actually occurred, the agency could initiate and contact members and say, you have a certain amount of time to make a change.
And I do think that part of what we're seeing is a result of COVID and lost revenues, inflationary pressure, all these things sort of coming to a head. So you've got regions at the table trying to keep it as low as possible. You have providers trying to recoup money maybe that they had lost over COVID, and trying to keep up with inflation and salaries and wages and all the things that happen. So it is always it's kind of an interesting part of the job. It's kind of exciting sometimes in a way.
So I just wanted to give some highlights there, knowing that it's coming up more and more frequently, and especially given the recent multi-care dispute that was public domain and the current legacy dispute. Any other questions about that?
Thank you, Dave. First up, we got Kate Walker, Policy Rules and Compliance Section Manager in PEBB, who's going to present a debrief of bills passed in the 2024 legislative season. His material behind tab number 4. Kate, welcome. He asked for permission to touch the mic. Okay.
You can even move it closer.
Yeah, you can touch all. There's no cords. You can do. Thank you, Chairman. You are welcome. Presenter.
I mean, it's cool new toys. I don't want to break the cool new stuff.
You are welcome. Presenter number 3.
Good morning, Chair, members of the board. Session is done. The last time I was here, session started, and wow, that went by pretty fast. I don't know about for you all, it certainly fast for us. So we'll give you a quick debrief about where, what happened, what is of note, and it's probably one of the shortest I've ever provided to you without the pressure of trying to actually zoom through. So, next slide, please. This is a slide I can always make sure I give a little bit of appreciation to the team that works behind the scenes to do all the work of analyzing bills during the legislative session. I give a shout out to the volume of work that gets done, 118 different bills just within the ERB division, that the team of over 30 bill analysts within ERB that assigned legislation to review. This is part of their responsibilities in addition to their regular job responsibilities. A lot of them who are in the room, who take on assignments, they just come when they come, and they have deadlines and timelines that say these have priority for you to pretty much not stop what you're doing, but you've got now 3 days, or in some instances 1 day, you've got to get this done. And that means you got to reach out to carriers, you got to reach out to regions and MODA, Kaiser, you got to reach out for whoever to go get that feedback, to go get working on it. It's a lot of work. So I want to make sure that the team that spends a significant amount of time during session working on this gets that shout out, because it's a lot of work. It really is one of those big team efforts that goes into this. And this chart kind of just puts it all together, helps kind of summarize 118 bills, probably accounting for thousands of hours worth of effort and thinking and analyzing, and reviewing, and more reviewing, conversations, fiscal analysis on that. Also, 72 fiscal notes this year was a pretty significant number. So shout out to our team of finance, which it's no small thing. I guess sometimes it's why we allow our finance director to buy our director, because some of those times can be a little bit tricky times. Maybe we'll get that video for it to see, maybe.
Maybe what Kate's referring to is, as part of the combined fund drive for the agency, I offered up somebody throwing a pie in my face, and it ended up being Megan Atkinson. And we did it on Pi Day, which was last week, and we recorded it. So just a little bit of fun there.
Megan paid $10,000 to do that.
Kate paid so that Megan could throw a pie in my face.
Oh.
You gotta send.
So maybe you can't touch that mic.
Can you just send it to White Fund Drive and then for next year?
Maybe we could generate
I don't want the competition. Okay, so thank you to the team. We had, so we'll move to the next slide. The 3 bills made through the process that we were tracking, they're the type of bills that we call the high priority for the ERB division, which are the ones that are going to have an impact on what we do. And we're responsible for tracking them because it's primarily focused on with the retiree benefits division. That's not to say that there's not other legislation that we're following, but the agency was following that had implications on the healthcare system as a whole. It's just that there was 3 pieces of specific legislation that were very much ERB focused piece of legislation that we talked about mid through, 2 of which have been signed by the governor, 1 which is still waiting for the governor to sign. Next slide, please. First on that slate of through the past is our agency request legislation that had the world's longest short title that I will not try and do in one breath or two. But this was our statutory cleanup, which was aligning the language between the budget language that has been in the budget for who knows how many years now, and the statutory language. It's aligning those pieces of language, reminding that this is not the alignment of that language does not compel the board to do anything. It doesn't direct the board to do anything regarding plans. It is merely just aligning that language to ensure that as the board contemplates different plan designs in the future, there's not any discrepancy or confusion about what the difference in those language may have as the board makes decisions. So that has passed and been signed by the governor. Next slide, please. Moving on, House Bill 2481. I don't know if at the time I had spoken to this, but there was a similar bill that the DRS had been running at the time that we were referring to as the month of death bill. House Bill 2481 is a similar kind of a subset bill from what DRS had initially introduced. This is one that we did help draft the legislation upon the request of the legislature. Again, House Bill 2481, waiving health benefit premiums in the Public Employee Benefits Board. This takes part of what the DRS month of death legislation was doing and kind of trimmed it down just to the aspect related to the premium for the retiree upon the month of death. Well, the DRS legislation was more comprehensive on the overall month of death payment for retirees. The 2481 focused more or specifically or solely on the month of death premium that is now going to be waived for the retiree in that month of death. And I think there's an important distinction or point I want to add on. Thank you, Fred Nancy, for reminding me of this from the last meeting, that the premium for any dependents on the account doesn't get waived, but we do auto re-enroll them onto the account once we've waived the member off of the waive that, and then the member sees the dependents who are on the account then get enrolled to their own account, and the premiums would then continue. But so it doesn't waive the premiums for the dependents on that month, just for the deceased. It's an important little mechanism that helps our accounting office not having to go after the estate or family members of recently deceased retirees. I'm not trying to claw back the last month or try to get the payment for the last month of death. Oftentimes there's pretty significant medical expenses in that last month. Last thing we want is there to be a cancellation of medical insurance for that last month. Allowing us to waive that last month of premium will ensure that there won't be that issue forward. A lot of administrative ease of that for our accounting department, as well as for the families themselves. So we're very happy and appreciate the legislature passing that. Look forward to getting that changed up in our system with effective date of 1/1/20. Moving on to some of the medical services changes, Senate Bill 6228. The rest of the bills that I will mention have not been signed yet by the governor. So I think the next time we report, if anything doesn't get signed, we'll report back to you. So assume that they'll sign unless you hear back from us. But nothing, the rest of those have not yet been signed. Senate Bill 6228, treatment of substance use disorder. This is expanding some of the accessibility of medical services available for mental health and substance use disorder, lowering some of the requirements for pre-authorization for inpatient treatments. Senate Bill 5821, standards for establishing relationships for audio-only telemedicine. Again, lowering some of the requirements in order to establish telemedicine. Currently, in order to establish, be able to conduct telemedicine, you have to have done an in-person consult visit with the provider. This allows for that initial consult now to be done via telemedicine to begin services with the provider strictly on telemedicine. Next slide, please. House Bill 1957. This is legislation that helps to codify parts of the Federal Affordable Care Act, specifically the portion of the Federal Affordable Care Act referred to as the essential health benefits. And this is a portion of the Affordable Care Act had many components of it, but the essential health benefits, it's a portion that says these are the required services that a health plan must offer if they want to be considered a qualified health plan and ergo be able to be covered under an exchange or qualify for federal subsidies. But in order to, essentially be a non-crap health insurance, I think it's a technical term.
Skinny.
Yeah,
We call them skinny.
that too. And so this is
That crap, I was like,
essentially we're covering things like dental services, pediatric services, pharmaceutical, massage therapy, and there's a list of requirements in the federal act. The state, I think, recognizing continued lawsuits on trying to repeal or legislative efforts on the congressional side to repeal either parts or the entirety of the Affordable Care Act, decided to codify in state statute the essential health benefits provisions of the Affordable Care Act in such time so that if there is a repeal or a legal challenge that is successful on the federal Affordable Care Act, that the essential health benefit requirements of insurance plans is now codified in state statute, thus requiring all health plans in the state of Washington. This would then go into effect, and all health plans in the state of Washington would be obligated to continue following the federal guidelines for essential health benefit coverage for all. I think it's kind of a cool little piece of legislation, though it doesn't have any immediate impact. It's that kind of, hey, here's a nice little backstop in the event that there is a successful effort to overturn part or entirety of it. Senate Bill 5986, further protecting consumers from out-of-network healthcare service charges for the balance billing. This relates to ground ambulances charges. So we've seen some other efforts in the past relating to the balance billing and surprise billing. In the past, we've looked at the legislature has addressed things like anesthesiologists, or emergency services, where we're getting ready to go into surgery. Oftentimes, you're not questioning, oh, my anesthesiologist, who I'm meeting for the first time, and he's giving me that happy juice going into my arm. Are you in my network? And you don't necessarily think about that at that moment, and then you get a surprise bill for a lot of money afterwards. So the legislation has been passed in recent years to help address that, expanding those concepts of not allowing for those sort of surprise billing. Now there is coverage and protection for consumers related to ground ambulances, which if you've ever had a ground ambulance transportation unexpectedly, which is usually probably when you have a transportation ambulance, it's a pretty expensive service. So we'll see. We'll probably continue to see more efforts on those sorts of services. The last two to speak about real quick here: House Bill 1979, reducing the cost of inhalers and epinephrine auto injectors. This is following similar suit to the legislative trend in the past of lowering the cost share to capping the cost share amount for consumers to $35 a month for 30-day supplies. Similar to what they've done this year for the inhalers and EpiPens, capping the cost at $35 for a 30-day supply for a inhaler for asthma, and then also capping the cost, I would also believe $35 for EpiPens. But we have worked on reducing those costs, and our pharmacists are very well aware of helping do that. Nice, fortunately for us, all of our plans are already meeting those cost requirements, but it now nicely standardizes that for all the plans.
Okay, does that become effective July 1st?
I'm not positive on the implementation.
One other piece on that legislation, and it came up at the sub-board meeting last week, was to highlight that legislation does not cover or include rescue inhalers. It's only corticosteroid or corticosteroid combination inhalers. The original legislation, I believe, was more expansive, but the ultimate piece that passed didn't include rescue inhalers, which is something important distinction for those individuals who use inhalers to know that the legislation didn't go as far to cover all types of inhalers.
Barry?
Yeah, Kate, apologize, mentioned this and I wasn't paying good attention, but on Bill 6094, regarding premium payments for a deceased member, status is that a past legislation or just a recommended, or
What was the bill number?
6094, Senate Bill 6094?
6094, Harry, is the subsidy, Medicare explicit subsidy alignment language. That one's been signed by the governor. The one I think you were just describing is maybe 2481.
Yeah, my fault.
The month of
Yeah.
death. That legislation has also been signed by the governor. It was not something that was on our specific radar for this session. The original legislation, we had partnered with DRS and the Select Committee on Pension Policy on a broader concept related to the month an individual passes that's a pensioner, but ultimately the legislature narrowed and addressed a subset of that issue for PEB.
Great, thank you. That was my, the other question I had is an earlier slide, you said there were, I read it, 3 bills, governor, and then you discussed 7. So I'm a little confused. Were those 7 all signed into law or will be, or
Oh, yeah,
is there a correlation here?
yeah, my apologies for the slide that you're referring to that has the funnel down. those are the pieces of legislation that we follow that are high priority and we're leading the agency analysis on it. I mean, you saw the slide before that we did 118 bills that we were tracking and did analyses on. So the funnel is more or less kind of just to remind you of like, oh, here's how a bill becomes law and has all these fun little cutoffs. And we were tracking obviously 6094 because that was agency request legislation from us. The significant impact, administrative impacts that 2481 would have for us. And there's a bunch of a lot of other pieces of legislation that we would probably have continued to track and could have left in there as well. But along the way, we try and track the ones that are continuing to move along. There was, if I had, I probably could have kept 21 different ones in there to show that there's 21, 18 along the way that had died along the way, but I prefer not to remember too many of those fallen ones.
I don't want to come across as picketing, but you mentioned a high priority. So I'm assuming that 2481 was a high priority.
But yes.
And so of the others, which ones were can you tell me were the high priority?
Yeah, it might be helpful for me to explain a little bit what a high priority means. So when in our terms, because again, this is kind of our jargon, I should probably change that, but high priority for us in the ERB ledge review sense has a very specific term. And when we're doing our bill analysis, we actually have an option of assigning, is this analysis a high priority or a low priority? And the bar for us kind of has a couple of different factors in our matrix that we're looking from. One of them is this have an implication on our rules and our policies, but it's going to cause us to have to go into whack, and my team's going to go in and say, all right, we've got to change this whack up because we're changing something in the statute, and now we're going to have to change up our rule. We're going to have some policy. We might have to bring something to the board to have a resolution done. So we're going to have to take further action other than just implementing the law that is, which would then often have low priority. Another way a bill might become a high priority for us to look at is there's a significant fiscal impact. Now, agency-wide, the significance of the fiscal impact is usually set about $50,000, which is an odd one for us because that seems like such a low barrier that almost anything that might have a fiscal impact is almost going to always have more than $50,000 impact. And so if there is a fiscal impact, it's almost always going to be a high priority for us. So if there's anything that's saying like, we're going to adjust the cost sharing for EpiPens. And if it wasn't something that we had already had in our plans, that would almost always make that bill be a high priority for us. So then there's a couple of criteria that we use for what would be considered a high priority for us. So as we look at the retiree bill, for example, 2481 about waiving that month of debt, while that doesn't have a fiscal impact for us, or it does have a fiscal
impact. That one has a fiscal impact because the state is going to receive less, $1.5 million less in revenue in the revenue side of the equation. So that is a fiscal impact of more than 50,000. So 2481 is one of them that fits the high priority. 6094 actually probably didn't get labeled as high priority because it has neither a fiscal impact nor a rulemaking impact. But do you know which other two would have actually met the criteria?
Yeah, I think 1957, I would have listed 1957 just because of the we got to follow that one and the implications it would have on carriers. Then anything that would other have cost implications, 1979 would have because of the implications, the cost implications, and because that was a commercial market. So where we were the other part of that chart is that we're the ERB is the lead. With the Medicaid program in house, we're reviewing probably thousands of pieces of legislation during the session. We're not the lead on a lot of those because a lot of legislation is coming through that is impacting the Medicaid program or is impacting Department of Behavioral Health Recovery specifically, and it doesn't necessarily impact ERB. So my apologies again. I think I'll.
No, that's okay. One other just clarification for me of the ones that you discussed. In context, is the presentation built around HCA vision view or just a PEB view of legislation?
An ERB.
I think you're right. ERB. Okay, thanks.
And I try and make sure if there are distinguishments between PEB and SEB, but more and more it does seem like I'm trying to make sure that the SEB program is aware of things that are impacting PEB and vice versa. Thank you.
Going back to HB 2481, David just mentioned that it would be out of pocket to the state of about 1.5 million. So does that mean the state is paying premiums to the carriers for those folks who pass away during the month?
Yes, the state is still paying the
So,
claim. the carrier, or in the sense of UMP, we're paying ourselves, because, you know, it's our own plan, and we're just taking a reduction in the net revenue that would go into the claims account from premium.
But we actually have to pay out to other carriers, outside carriers.
We would continue to
Okay.
pay the premium to
Okay.
Kaiser or Primera or Plan G, for example, or United Healthcare. We would continue to pay the premium out to each of the plans.
And just the last one on the last page, commenting on the passage of Senate Bill 6127 was increasing and lowering some of the barriers for access to HIV post-exposure prophylaxis or PEB treatment. And with that, those are just those that passed that we've been tracking. There were a lot that didn't make it through because it's a sort of short session. All of the legislation that didn't make it through is now officially wiped off the slate. Next session will be the start of a new legislative season and all new numbers, and we'll start the process over again. We are already in preparation for next season. I did the first thing out of my mouth, I think at our PERB management team meeting the day after, or I think the day of Sine Die was, all right, what are we doing for next year? And so we're already starting to think about and start planning for next session. So again, I wanted to send my appreciation to the team. A lot of hours going through. Thank you to the legislature and everyone involved in the process. It's a nice opportunity to move the football forward down the field a little bit, gain some yards, and then we're gonna put things into effect and try and make things a little better for everyone. So I'll be happy to answer any more questions about session. Otherwise, maybe the last I think you hear about me for this until next.
And Harry, I think that's a good point. You know, the bills, the lens at which we look through the bills and how we articulate that to the board, I think there's some work there. Because it is true, there's some bills that we're not a high priority on. We are ancillary to the bill, but it does have a little bit of impact on us. So we'll work on that. Yeah. Questions for Kate? Okay, Kate, thank you so much. Appreciate it, sir. Next up, Jenny Switzer, Senior Account Manager in the Employee and PEBB. We're not going to say the short version. PEBB is bringing us information regarding pharmacy retail consolidation, marketplace trends, materials behind tab number 5. Saying there's consolidation in the healthcare industry. Yes, that's what you are saying.
All right. Good morning, Chair McDermott, members of the board. Like you said, my name is Jenny Switzer, and I'm the UMP Senior Pharmacy Account Manager in the Employees and Retirees Benefits Division of HCA. Today, I'm going to talk about, I'm going to provide an overview of some changes we've seen with retail pharmacies recently. So on the first slide, you can see I've outlined the types of pharmacies available in the US market. The first one is retail chains. So those are those big box type pharmacy locations like Walgreens and Rite Aids. From 2010 to 2020, there was an industry-wide focus on mergers and acquisitions. So we saw a lot of growth in the retail chain market. As an example, CVS acquired 1,700 Target locations, and Walgreens acquired 1,900 Rite Aid pharmacies. Now we're seeing more retail chains closing or filing for bankruptcy as sales of those locations have declined. And we're going to look more at that in upcoming slides today. Regional pharmacies are pharmacies located within retail stores. Their numbers continue to increase as there have been large retail acquisitions of grocers in recent years, resulting in the addition of pharmacies in these retail locations. These locations make it easier for people to purchase drugs while grocery shopping, thus reducing the need to travel to multiple locations when they're out and about running errands. Independent pharmacies continue to see decreases as more retail chains and regional pharmacy locations open, as well as the growth of mail order pharmacy options. And mail order and online pharmacies continue to see growth as they make refilling medications easy for members with direct shipping. Their options offer convenience of having drugs delivered directly to you and allow prescription tracking by text notification and app services. On this next slide, I've outlined the differences in the count of pharmacies nationwide and within Washington between 2019 and 2024. As you can see, we're going to talk more about Rite Aid and Bartell later, but as you can see, they account for more than half of the total loss of network pharmacies. Our pharmacy benefit manager, Moda Health, continually continually works with their subcontractor Novitus to enter into new contracts to ensure that members have adequate access to pharmacy locations. There is an error on this slide that was discovered just a couple of days ago. But it's a positive error for us at least. The network pharmacies in Washington in 2019, the count was actually 1,110. And in 2024, which that says 23, but it's 24, there was 1,131 pharmacies. So this is actually a positive of 21 total network pharmacies within Washington state. As I said, that's due to the efforts at Novitus to continue to outreach to pharmacies to grow the pharmacy network. There's many changes in the retail pharmacy industry affecting availability of network pharmacy locations, and we're going to look at those on the next slides. So pharmacies open and close regularly throughout the year, just like any business or location would. On this slide, I've gone over some of the most common reasons that we find for closures of pharmacies. First here is increased competition. Like I've mentioned in previous slides, online businesses like Amazon and big box stores like Walmart are expanding their footprints and offering competitive pricing. Although the addition of pharmacies and more grocery stores and mail order options are a benefit add for our members, it does have downstream impacts to retail pharmacy locations. One of those being that foot traffic in those traditional pharmacies does decrease, impacting front-end sales and overall revenue. Second, here we see the economic impact of lower drug reimbursements can result in reduced profit at chain or independent pharmacies. Competition from those online retailers and retail stores has led to pressure to fix pharmacy costs, such as reimbursement rates at all pharmacies. Without the additional revenue from other sources, such as you would find in grocery stores, many chain and independent pharmacies see negative financial impacts as a result of those changes. Not shockingly, reduced in-person traffic during COVID-19 did reduce profits at several locations, especially independent pharmacies. During that time, many people did switch to retail pharmacy locations as they desired to go to less locations. Unfortunately, a lot of independent pharmacies did not see people return after COVID calmed down. State and federal regulations have added administrative burden to pharmacies, enhanced requirements around proper handling of prescription medications, specifically opioids, has added time and additional processes to the prescription filling process, which increases overhead costs at pharmacies. And of additional note, many pharmacies have faced lawsuits and hefty fines relating to those opioid drug distribution process changes. Some locations have had to file bankruptcy or close as a result of those changes. On the next slide, we'll look at UMP's response to these pharmacy closures. So Moda Health works to ensure appropriate access to network pharmacies for our members. That includes many aspects that support network pharmacies to ensure availability of locations. They work diligently to identify gaps in access to pharmacies by entering into contract negotiations, as I mentioned before. As of the 2023 Geo Access Report, which does look at urban, suburban, and rural areas, as you can see on the slide, 99% of PEB subscribers had appropriate access to network pharmacies based on their zip code and geographical location. And they MODA continually watches for areas where we can improve and add more pharmacies. Are you going off mute?
Yeah.
It's really a question because this comes up a lot from members of RPEC. Is MODA a PBN or is MODA an administrator, and what's the difference?
MODA is a pharmacy benefits management company. They assist us with contract negotiations with pharmacies. They do claims administration. They do that administrative work with us. So if you look at the definition of PBM, pharmacy benefit manager, MODA does fall within that definition.
Who owns Moda? How's it owned?
I can look back to Mona. I don't know the answer to that question. We will,
Curious if it's owned by a corporation or.
What say you, Mona?
I'll talk with Chris, and then.
We got covered. John?
Dave's gonna run over and do some research.
More than a pharmacy, it's healthcare.
Well, I know, but I was just wondering if it's a public corporation or. It's privately held.
They've got naming rights to that Portland Trail place.
Yeah, right.
Yeah.
Lotus Hunter. Which is,
So what, I should find out the role by you know in healthcare. Or something like that.
Might be a complicated answer. Yes, sir.
It is a complicated answer. So like a lot of health insurance, parts of our health insurance industry, there is portions of organizations that are owned and controlled by different entities. So we'll bring it back as part of the follow-up, either in a agenda presentation, if there is one in April, or as Dave cleaned up at the beginning of the meeting. So we'll flag that one because it is complicated, is the short answer.
And just to make clear, the reason I asked, was I wanted to see if, like, for instance, ultimately the owner was United Healthcare or some company that we do business with another
Got it.
area.
Okay, we'll definitely bring that as a follow-up next meeting. It gets complicated quickly is the short answer.
Among members, they don't know the difference between the two and there's suspicion. So it would be great to have kind of one-on-one. This is a PBM, this is what do you call it, the contractor or the
Subcontractor.
subcontractor, the administrator, all these terms, so you guys know what it means. We don't. Well, I can't speak for the members of this board. They may know, but. I'm not
It is complicated, even that relationship. So I think we
And-
presented on that.
It'll be better for us to resurrect some prior presentations and not try to define them off the cuff right now, but we understand the confusing aspects of that. So we flag things for follow-up, and this is definitely on the follow-up track.
I think what might help is when we're considering a new drug plan, it would be great to give examples with respect to that drug plan under consideration so that people can relate.
All right. So, and then the next spot here, fair pharmacy reimbursements and contracting. Novitas does work to ensure fair pharmacy pricing and contracts is applied across the board at pharmacy locations to ensure those pharmacies are not charged additional fees or penalized for outcomes that they have little or no control over. On the next slide, we'll look at the Rite Aid and Martell drug bankruptcy that I'm sure most of you, if not all of you, have heard about in the news. So for a little bit of background, Rite Aid did acquire Bartell Drugs in 2020. This is during that period of growth that I spoke about earlier. In October of 2023, Rite Aid did file for bankruptcy. And in November of 23, Rite Aid and Bartell Drug stores started closing as a result of that bankruptcy. The first store that closed that impacted PEB members was on November 6th. And the bankruptcy process was finalized on March 1st. That doesn't mean that they are ultimately fully done closing stores. We're continually watching this. I have updates to the slides because Moda was able to provide updates just yesterday. So we're watching it very, very closely. As of this week, 23 stores in Washington have closed. And on the next slide, we'll look at those locations and total of impacted PEB members. Here you can see the Washington locations that have closed as a result of the bankruptcy. Additionally, I included how many UMP members utilized those locations in the 6 months prior to the location closing. And so the information on this slide is accurate as of last week. However, as of yesterday, there's a little bit of a difference. There was one additional pharmacy in Seattle that closed. And so as of this week, hot off the press, 23 network pharmacy locations have closed in Washington state with just over 6,600 PEB members impacted that have filled prescriptions at those locations within the past 6 months. On the next slide, we'll look at distance to the next nearest pharmacy. So updates to this slide as well. When there are pharmacy closures, one of the biggest areas that we watch and we ask for information updated regularly on is the impact to our members. How do our members have to travel further than they had to travel prior to get to a network pharmacy location? So pretend that this slide, instead of saying 21 on each of those bullets, pretend it says 22 because that's accurate. As of yesterday. So 22 of the 23 locations that closed have at least one network pharmacy within a half a mile of that closed location. 22 locations that closed have at least 2 network pharmacies within 1 mile of the closed location. And 22 locations that closed have at least 3 network pharmacies within 2 miles of the location, the closed location. Any questions on this slide or location to next time? And of note on the next nearest pharmacy is sometimes those members, they may have filled 1 prescription at a closing location, but we can tell that that's not their regular pharmacy. Because sometimes you go to a walk-in clinic and you just go to the nearest one. You don't want to have to drive across town to your regular. So, but this gives a whole picture of everyone impacted. On the next slide, we'll look at what we've done to notify members of these closures. So we obviously want to make sure that members are receiving proper notification and feel that we are keeping them up to date on what's going on. So HCA and MODA collaborated to develop a letter that was mailed to 6,900 members who utilized the closing location within the past 6 months. Those letters include name and address of the pharmacy that closed, MODA's website and phone number for members who need help finding a different network pharmacy, information on how utilizing network pharmacies can save you money, information about our drug price check tool, and instructions on how to switch their prescriptions to a pharmacy of their choice. We also created 2 smart health activities to help members. One focused on information about network pharmacies, including the lower cost share when using a network pharmacy and how to locate those pharmacies. And the other provided detailed information on how to transfer prescriptions between pharmacies. Sometimes your pharmacy can just transfer your prescription, but other drug classes, your physician actually needs to send in that prescription to your pharmacy of choice. We do have a third smart health activity that's launching here in the next week or so, which gives more information about the drug price check tool. So that members know, because I think there might be some belief that you can go to any pharmacy and you're going to pay the same price at every pharmacy that you go to. Each pharmacy is independently contracted with, so you might pay 25 cents at Thriftway down the road, but then you go to Walmart over in Tumwater, and you're going to pay 52 cents. Usually it's not that drastic of a margin, but providing more information to members so that they can make the best choice for them.
And Jenny, I think we learned and highlighted last week that you do not have to be a member of UMP nor have a login to access that tool. Anyone can access it regardless of the plan they're in.
So it's a helpful tool, especially during open enrollment when people are considering which plan that they want to join. They can look at that to see what their drugs might cost at locations near them.
Eric.
Curry, are you getting any feedback or any questions along the way about should I use Amazon pharmacy or well, maybe someday it will, or cost plus, because you read a lot of testimonials, anecdotal about how people say using that line is Amazon less than the health plan that I'm in. I don't know if that applies here, just what I read. So I was just curious if you're getting any inquiries about that.
For HCA, because I would have seen those, we have not. I can inquire of MODA to see if they've received any calls on that. The interesting thing, even though mail order pharmacies continue to increase, for our UMP populations, it's actually a very small population that uses those online services. The UMP population seems to really enjoy just going to the store and picking them up.
Elliot.
Quick question. You mentioned that website, which helps you compare. In your next presentation, could you put it in?
I can. Yep.
Because members really appreciate that. I often get questions, well, what is HCA doing for us? It would help.
So I guess I'm coming back for another presentation.
Or it might be in my follow-up.
Okay.
We'll see. Or it could be an Ellen's follow-up, because Ellen's often with us.
All right, and then lastly, on this, our outreach to members, we did post an alert on the UMP website, so when members logged in, it just popped up on their screen that there's gonna be closures, here's where you can go to find it at the pharmacy, here's the drug price check tool. And we're also looking at, you know, other ways of making sure, like you questioned, the price check tool and how it's a great tool. We're actually looking at how can we make that more available to people and on an ongoing basis. So we're gonna include it in upcoming newsletters. It's gonna be a bigger focus in open enrollment materials. We're giving more focus to including it in our certificates of coverage as a big point. So we've definitely spent a lot of time over the last few weeks looking at how can we make this more available to people, because people seem to really enjoy having access to that.
Maybe on our social media account as
Oh, yeah.
well. Might be a good
Good
idea.
idea. So this does bring me to the end of my presentation.
Questions or comments? Thank you, Jenny.
Thank
Appreciate it.
you.
Next up, we have Andrea Billhauer. She's the fully insured team manager in PEBB and is bringing back some more information regarding the behavioral health network adequacy presentation given at the February retreat. Her materials behind tab number 6. Andrea, welcome.
Good morning, Chair McDermott, members of the board. For the record, my name is Andrea Billhauer. I am the manager of the fully insured team in employee and retiree benefits. Before we talk about network access, I want to take a moment to correct some information that I provided you at your board retreat last month. When I was talking about the Affordable Care Act, I meant to define actuarial value for you. And unfortunately, what I defined was the concept of medical loss ratio. So I just want to clarify, here is the correct definition of actuarial value. Actuarial value is the percentage of total average costs for covered benefits that a plan will cover. So for example, if a plan has an actuarial value of 70%, that means on average, the member will pay about 30% of the costs of all covered benefits. There are factors that could result in a member being responsible for more or less of the average cost, but this is the basic concept. Any questions about that?
I realize, even though I've thought about this presentation many times over the last month, a logical question could be, well, what are the actuarial value of the plans in the PEB portfolio? And generally they are all above 80%. We hit some that are in the high 80s and even low 90% of actuarial value from year over year.
The main purpose of my presentation today is to answer a question that was asked at your board retreat. At that retreat, I talked about WAC 284-170, 285-5C, which sets forth the time limits within which a member must be given an appointment when they request mental health and substance use disorder treatment services. And if you recall, that regulation requires that a member must get an appointment within 10 days or within 15 days if the service requires referral or specialty care. Where the member is unable to schedule their own appointment within that time, the carrier is required to help them get an appointment. Next slide, please. I first want to clarify what this regulation actually requires, because there are two concepts here. The first concept is the amount of time that a plan has to schedule an appointment. And the second concept is the amount of time that can pass before that appointment has to actually occur. I'm going to call the first concept time to schedule, which is what the regulation addresses. So under this regulation, a plan must ensure that its members can schedule an appointment within 10 or 15 days to receive covered behavioral health services, but the appointment does not have to actually occur within 10 to 15 days. So that's the second concept, which I call time to visit. Slide, please. Which gets us to the question that was asked during the board retreat, which was who monitors to make sure that plans are meeting the time to schedule requirement? And the answer is that access to behavioral health appointments is monitored by both HCA and the Office of the Insurance Commissioner, OIC. First, we'll talk about how HCA monitors access to behavioral health appointments. Our goal is to closely monitor the time that it takes for a member to access behavioral health services and then to improve that access. Behavioral health is a high priority for HCA as a whole in all of our programs, including employee and retiree benefits. HCA is actively working to highlight behavioral health services in our public-facing materials to the same extent as medical services. In addition, we're making changes to ensure that behavioral health is a focus of our workforce. In ERB, we address behavioral health with our vendors in several ways, and particularly access to services. One way that HCA measures time to schedule and time to visit is through the use of CAHPS surveys. CAHPS is the Consumer Assessment of Healthcare Providers and Systems, which is an entity funded by the Federal Agency for Healthcare Research and Quality and the Centers for Medicare and Medicaid Services. CAHPS develops and administers standardized surveys to a huge sample of patients. The surveys ask about the patient's experiences with their healthcare. And among the questions on those CAHPS surveys are questions about patient satisfaction with how long they had to wait for services. In our contracts with vendors, we require our vendors to submit their results from their CAHPS surveys. And although this is not a direct measurement of compliance with state timelines, the results do have financial consequences tied to them, which means if a vendor is getting poor scores from members who feel like they've had to wait too long for appointments, then that could cost the vendors a percentage of the amount HCA would normally pay them. Another way that HCA monitors access to behavioral health appointments is through direct engagement with our vendors. Each of our vendors is required by contract to provide us at least annually with status reports on their PEB plans. And during these meetings, which have returned to in-person as much as possible after the pandemic, we look together at areas where we see issues with timely access to care. Of course, one of those big areas is behavioral health, since we're in the midst of a provider shortage and a changing landscape of how behavioral health care services are provided. Where we see issues, we have conversations about what the carriers are doing to improve access to care. We work together to determine how we can improve access. If you recall, last month, Dr. Schultz presented some detailed information about the avenues our vendors have for members to get help. There's also work going on in many areas to expand access, such as mobile providers and the stand-up of the new 988 crisis hotline. More on that in a bit. Next slide, please. Turning now to how the Office of the Insurance Commissioner monitors access to behavioral health care. In general, OIC monitors time to schedule and time to visit through consumer complaints. That is, complaints submitted through the OIC's complaint system. At the PEB board retreat, we talked about the general standard for network access. Members must be able to obtain covered services from in-network providers without undue delay. That applies to all areas of service. OIC tracks complaints and violations of this general network access standard. And the number of complaints is pretty low. Since 2018, OIC has received a total of 29 complaints on this, about 6 complaints a year. But more specific to behavioral health, OIC is required by WAC to track and post a report of complaints specifically asserting that a consumer could not access mental health or substance use disorder services within that 10 to 15 day time to schedule standard during the prior year. A note about these numbers, the consumer advocacy staff at OIC logs complaints using keywords. And so the numbers on this report might seem inconsistent with the numbers for the more general complaints. And that's because calls specifically about inability to timely access behavioral health services use a different keyword. Last time I talked about Brennan's Law, which requires certain mental health and substance use disorder treatment information to be posted prominently on carrier websites. Brennan's Law requires that part of this posted information must be a link to this specific report. So on the next slide, you will see results in
Real quick,
OIC.
we're gonna pause Kyla's question.
That's more of a comment or a question of asked to like carry this forward in some way. I think talking about just access to information and understanding of how to file a complaint or what to do. When I see like 6 complaints, a number being low, but like I work for the government, I don't know how to contact the OIC to file a complaint. I don't know, I mean, I know after I go to the doctor, I get some sort of follow-up email, but I'm not really sure like what to do or how to file a complaint, even if I did have to wait. So I guess it's more of just like not a direct ask, but how do we get this more accessible so that we can have a more accurate understanding of what the reality is for people?
Yeah, and I appreciate that, okay, because it's also saying, just because the number's low doesn't mean that there aren't issues.
Right.
Which isn't what we're trying to say either, so that's an excellent point about,
Right.
thinking about how to get that word out more. And Sharon?
Thank you, David. And that was my question too. How is this being publicized to the public? To know that this is an avenue to access that information. And that's what I would like to know. How is that being?
I think the answer to that is twofold. With respect to the OIC and their complaint line, they have a number of avenues that they publicize. One of the things that I talked about a little earlier is that we at HCA are working actively right now to improve our information to the public about behavioral health care and access to it. And I think that one of the things that the group that I happen to be part of will be working on is exactly that, is making sure that people know where to go and who to contact when they have trouble getting those appointments.
You know, I was kind of interested, Makata, when you said that, so I went to the OIC website. On their very front page, the very first, how do I file a complaint? So they do a nice job, but again, knowing as a citizen is the OIC is the regulatory
Right,
body over
exactly.
them is the challenge, right?
Exactly. And I think if, people who have PEB plans are thinking, I need to contact PEB. So we do, and we are going to, we do need to do a better job of that. And we're, as I said, there's active work going on with that right now.
Sort of an expansion of health literacy, all the components of healthcare, and there's a million. John?
I have a couple of issues with clients who tried to get specific types of behavioral health. In this case, it was actually several cases, neuropsych evaluation. And the University of Washington's hospital is taking 9 to 12 months to schedule those. Even no matter which kind of insurance you have, which kind you had. How does that work? Is that something people would file a complaint? Would that help?
That is, and I'm gonna talk about this a little bit later. That is something that is very much on not only Washington's legislature and the OIC's radar, as well as HCA's. It's also on the national radar. I'm gonna talk about this a little later, but OIC is waiting right now for the next 2025 plan year rules to come out that apply to plans that are subject to the Affordable Care Act. And they're expecting that the federal Congress may do something about that, or CMS may do something about exactly that, because they've been signaling that they're going to.
Is it a lack of providers?
It's a lot of things, and one of them, yes, is lack of providers.
Elliot?
Thank you. Getting back to access, you might want to look at both retired and current school and state employee newsletters, at least with this information, so people know who to contact, because it isn't obvious. It isn't intuitively obvious, like you're saying.
That is an excellent idea, and your timing is good too, because you're working on that right now.
Oh.
Yeah, it's actually a great opportunity. I forgot to say something earlier. We finalized, it's March, but we finalized our main newsletter, which is the next newsletter that goes out. We're gonna do some article in that. There's gonna be an article about the provider contracting dispute process, and some of the points that I raised at the beginning. And so this is great fodder, Gene, for potential newsletter articles in the future.
Well, yeah, there's your newsletter, but also it couldn't hurt to repeat it in the education, retirees, current, and in the state employee current and retired newsletters, because some people look at your stuff, some people look at the organization's newsletters.
Harry?
I heard the time to schedule 10 to 15 days. Did you mention the time to visit? I don't recall.
There's not, at this point, there's not a requirement for a specific time to visit. And that's really what we're looking to see if maybe the CMS might do something about that. And like I said, it's very much on everybody in Washington, the right Washington's radar. So I would expect that something might come up, but there might be some requirements coming in the future for that. At this point, though, there are none.
Just one question, in terms of time to schedule and time to visit.
Sucker down
There it is. I don't project very well,
You're
unfortunately.
good to go.
In terms of time to schedule and time to visit, are there variations for, say, youth versus adults, in terms of that period of time?
There are not. The difference, the 10 to 15 day difference is, it's 10 days if there's not a requirement for, a referral, or if it's not a specialist that the patient or the member is trying to see.
And the reason why I asked, I'd love to see the data in terms of that, that time period based on that particular demographic, particularly for the youth. So I'd love to be able to have access to that.
I see Dave writing, so
Yeah.
I suspect that there's an assignment in my contract.
Or someone's.
Or someone.
Plenty of people at HCA that aren't at the table right now.
That's correct. So looking at the results in OIC's report of complaints, specifically asserting that a consumer could not access mental health or substance use disorder services within that 10 to 15 day time to schedule standard during a particular year, I am showing you the last 3 years that we have full data for. And I want to note that these are complaints only. These are not confirmed violations. The carriers that provide PEB plans are in red, PEB and SEP plans are in red. And this is very limited data. We really can't draw any conclusions from it at this point. The numbers would appear to be going up, but there's no telling whether that's an anomaly or a real trend. If it is a real trend, there's no way to know what might be behind it. This is a very hot topic right now, federally and in Washington state. As I said, we're currently awaiting final changes to the federal rules for plans subject to the Affordable Care Act for plan year 2025. The OIC is expecting that the federal government might pass some new rules in this area because they've been signaling for a couple of years that they intend to. And in Washington, this is also very high on OIC's radar and also the legislatures. The House Health and Wellness Committee recently requested that OIC present to them regarding network access standards in general. And this very topic was discussed. So stay tuned because we expect to be hearing more about this. Next slide, please.
Real quick, Andrea, so I was reading notes. I don't know if you said this, but I wanted to make sure to highlight that the numbers on slide 9 aren't necessarily PEB or SEP numbers. They are to the carrier. So we can't say, you know, that a subset of them were or weren't PEB and SEP. So just wanted to highlight that as well.
So in this regard, we wanted to make you aware of a statute that affects health plans beginning on or after January 1st, 2023. It reflects the efforts being made to ensure that people who need urgent behavioral health care receive it. Next day appointments have been available for people on Medicaid and to people without medical insurance. But now this law requires that many commercial plans connect their members with next day appointments. Just a reminder, this statute applies to the commercial insurance market, so it does not apply to self-insured plans like the Uniform Medical Plan. This statute requires health plans to make next day appointments available to members who call the 988 mental health crisis line in certain situations. Little about the 988 crisis line. People in crisis or those who are worried about someone in crisis can call that line, and it's staffed by trained crisis counselors. The 988 crisis line is operated by a number of federal agencies led by the Federal Substance Abuse and Mental Health Services Administration, or SAMHSA. 988 is available nationally via call, text, or chat. The crisis line was created to increase collaboration between crisis service providers, and it aims to reduce the use of emergency room and police departments to handle mental health crises, and improving access to care for those who need it. SAMHSA's behavioral health crisis care best practices identify 3 necessary parts of an effective crisis response system: someone to talk to, someone to respond, and somewhere to go. Scheduling or connecting someone to outpatient services, including next day appointments, is part of that 3rd prong, somewhere to go. That's where this law comes in. The law requires health plans to make a next day appointment available to members who are experiencing urgent symptomatic behavioral health conditions. That is, if they're showing behavioral signs or symptoms that require attention and assessment within 24 hours, but do not place the person in immediate danger to self or others. For those members, a next day appointment is a tool to help them start to resolve their crisis. Ensuring safety is the first step in all crisis interventions. For a next day appointment to be effective, the person must be safe enough to wait the hours or even days in some cases until they're seen. They must also be in a condition that would allow them to follow up and actually attend that appointment. Next day appointment is meant to be an immediate support to a person in crisis to get them connected quickly with a professional or peer who can address a key concern that's causing or exacerbating their crisis and keep the member safe. 988 crisis lifeline crisis counselors can connect people to next day appointments directly if the counselor clinically determines that to be an effective intervention. Someone who receives an in-person response can also receive a next day appointment. So if the person can't stay safe or meet some of the requirements for a next day appointment, that person can still be connected to a next day appointment once their safety concerns are resolved. Next slide, please. Statute provides some detail as to what the next day appointment can look like. These appointments may be provided by telehealth and by any medical professional operating within their scope of practice. They can be scheduled literally for the next day, or if it works better for the member, a different time that the member agrees to. The crucial requirement is that the appointment happens soon enough to help the person resolve the problems that the appointment that contribute to their urgent behavioral health situation. That's the purpose of these next day appointments. They're meant to be a step to resolving the crisis and accessing further services. They're not intended to be ongoing crisis interventions or stabilization services provided by crisis workers. They serve as a step to resolving the crisis and helping the person get additional services. Next day appointments are for things like medication consults, appointments with a primary care provider or other clinician or prescriber, intake assessments, tribal health services, and other consults. Since 2022, when this law passed, commercial insurance plans have been required to cover services accessed through calling 988. Prior authorization cannot be required, but there are some significant challenges to implementing that requirement centered on connecting the patient to the payer. In the crisis system, patients are typically not asked for insurance information, which works fine for Medicaid clients who are served by funding from Medicaid Behavioral Health Administrative Services organizations or by the Medicaid Managed Care organizations. That work is all performed on the back end to make the crisis response easier to manage. But there are currently no back-end processes to match callers to their commercial insurance plans. Work is ongoing to create a system to do that matching, but it's taking some time to work that out. And just to provide an example of the problems, it's true that if the caller makes a next day appointment and the member does attend that appointment, the provider can get their insurance information at that next day appointment. But one of the problems here is that a large percentage, estimated to be in the high 80% range, of issues are resolved during the 988 call. Next slide, please. The statute requires each carrier to report its compliance to OIC, which they do each month using a form called the Network Access Form B. We want to be on slide 13, please. Sorry, I keep forgetting to say it. Next slide. So the reports are received by OIC's Provider Network Access Unit as required, but the carriers are doing what they can. But as I explained earlier, there's not yet a smooth way to match 988 callers to their insurance providers in all instances. So OIC and the commercial carriers acknowledge that these reports are not accurate yet. The stand-up of the 988 system is still in process, and OIC is working hard with all the parties to work out payment structure. But the good news is that callers are getting the help that they need when they need it. Next slide, please. We reached out to the current medical vendors providing healthcare to PEB members and asked them to let us know whether they are in compliance with this statute. Kaiser Foundation Health Plan of Washington and Kaiser Foundation Health Plan of the Northwest both offer same day or next day behavioral health appointments. They've also instituted an audit process to make sure they're meeting these requirements. In addition, these companies offer a number of online behavioral health support programs. These include Calm, which is an app to help with sleep and meditation, Headspace Care, which used to be called Ginger, where members text one-on-one with an emotional support coach, and My Strength, where members build a personalized plan to strengthen their emotional health. Kaiser also offers available wellness coaches and emotional support coaches. I don't have a specific slide for this, but we were asked a question about whether, what behavioral health support programs are available specifically for older members. Generally, the behavioral health programs and benefits offered by PEB don't focus specifically on older members, but they do offer services and support for aging-related stress, medical conditions, and depression as part of their provider and vendor programs. And United Healthcare does partner with Older Adults Technology Services, OATS, to assist with digital and technology training and programs for vulnerable and low-income older adults. Also, Kaiser notes that more than 8 in 10, or 83% of its Medicare population has access to the internet. Which brings us to questions.
Sorry, I have a couple of questions on the very, because I'm a psychologist. Supports for the caregivers.
No, you're Mike, there we go. Yeah, you may have double clicked.
Yeah. Plans that really provide supports directly to the caregivers of these patients. How might that work? Or we have information.
I don't right this minute, but I see Dave writing.
I mean, that's a huge issue on both
Sure.
ends of that demographic for the younger children, but certainly for our older adults as well. And assuring that those who are caring for them really do have the right supports to address those needs. So thank you so much.
That's a great question. Thank you.
Other questions or comments? Andrea? Thank you so much, appreciate it. And yes, looks like we're gonna have some assignments. Why don't we go ahead and take a break until 10:45 and come back together then. There you go. All right. Thank you so much. Next up, Stella Inc., Policy Rules Coordinator, and Emily Shane, Regulatory Analyst in ERB, are going to introduce policy resolutions for the PEB program. No action scheduled for today, but I assume next board meeting will be bringing those. That's normally the case. Materials are behind tab number 7. Stella and Emily, welcome.
Thank you. Good morning, Chair McDermott, members of the board. My name is Stella, Policy and Rules Coordinator from the ERB Division. Emily Duchesne and I have 11 proposed policy resolutions to introduce. Next slide, please. This slide and the next slide are included in the presentation, so the board have them available as you consider the policies we will discuss. Slide 4, please. Here are the 11 proposed policy resolutions we introduced. Emily Duchesne will go over the first 10 proposed resolutions that address dual enrollment provision or implementing PEB vision coverage. And I will go over the last resolution that will amend the deferral policy for PEB retiree insurance coverage. Our goal today is to introduce these policy proposals to the board, get your initial insights, and prepare the board to take action on these resolutions at the next board meeting. And I will let Emily go over dual enrollment provision resolutions with you.
Thanks, Stella. Hello, Chair McDermott, members of the board. My name is Emily Duchesne, and I am a regulatory analyst with the Policy, Rules, and Compliance team within ERB. Today, we have 10 proposed resolutions for you to consider. At our April board meeting, we will be asking you to vote on all 10 in one motion. Because there are some new members on the board since we last passed these in 2021, I will be reading each proposed resolution in its entirety. And there will be a point where I pause for questions if anybody needs them, and then once again at the end. Just a quick overview before we begin. We are amending PEB 2021-02, 2021-03, 2021-04, 2021-06,
2020-108, 2020-109, and 2021-25, simply to just include PEB vision where necessary, since PEB will have standalone vision in plan year 2025. We will be amending PEB 2020-105 and 2020-107 to address how dual enrollment is resolved when an employee or an employee's dependent is dual enrolled in medical or in both programs without medical. Those get a little bit more involved, so I'll be going into detail for those two resolutions with you. And then we will also be asking that you rescind PEB 1022-02, employees may waive enrollment in dental, and I'll go into more detail as to why on that slide. Next slide, please.
Real quick, Emily, I just want to highlight before, we usually like to have the resolution read into the record multiple times. We're just going to do that at this meeting, and the next meeting we'll also ask you if you're okay with suspending the chair reading them as part of the motion practice. So I just wanted to prepare you for that. I know Lou or Sue would be really excited to read every single word of 10 resolutions, just as was the case with the original batch. And just highlighting that we want to suspend hope to suspend some of those formalities at the next meeting during the action step, but do want to make sure that we do the deep dive here. At a fundamental level, as Emily gets to these, I just want to highlight they aren't a departure or significant change from the underlying policy direction and decisions that were made back in 2021 or 2022. It's really to incorporate the shift to standalone vision benefit within these sets. So hopefully there aren't too many questions about the general direction. These are refinements. They aren't wholesale new policy debates. And a gentle reminder that dual enrollment is prohibited by state law and in statute. So there's not discretion really for whether dual enrollment can be prohibited. It's how and the enrollment policies that we bring to you. Back to you, Emily.
That's right. Thanks, Dave. So as Dave said, dual enrollment is prohibited under RCW 4105-742. As of January 2025, in both the PEB and SEB programs, the employer pays the entire vision benefit premium. And when we say, so throughout the next few slides, and this is the same way it was when we initially presented these resolutions back in 2021, when we say the word employee, we mean a PEB employee. When we say the words school employee, we mean a SEB employee. Next slide, please. Okay, let's get started on it. Oh, yes.
Do you mean an active employee or do you mean retired employees as well?
Active employees. The dual enrollment resolutions do not apply to retired employees. Yeah. All right, proposed resolution PEB 2024-01, amending resolution PEB 2021-02, employees may waive enrollment in medical. An employee who is eligible for the employer contribution toward PEB benefits may waive their enrollment in a medical plan if they are enrolled in other employer-based group medical. Exception: an employee may waive their enrollment in a PEB medical plan to enroll in a SEB medical plan only if they are enrolled in a SEB dental plan and SEB vision plan. In doing so, the employee also waives their enrollment in PEB dental and PEB vision. This is simply incorporating PEB vision into this resolution. Next slide, please.
As we transition away, another good reminder is there are often mirror resolutions that the SEB board passed. So just a reminder that each board only has authority over its own enrollment procedures. So sometimes it's like catch and release. The resolution releasing them for one program, there's an inverse catching resolution in the other program. So just you only see the resolutions that are your half of the equation, but the SEB board has the other half of the relevant equation, which is catching or releasing them to you guys. So just highlighting that.
Thanks, Dave. Proposed resolution PEB 2024-02, amending resolution PEB 2021-03, PEB benefit enrollment requirements when SEB benefits are waived. A school employee who waives SEB medical, SEB dental, and SEB vision for PEB medical must be enrolled in a PEB dental plan and a PEB vision plan. If necessary, they will automatically be enrolled in the associated subscribers PEB dental plan and PEB vision plan. Once again, incorporating vision where necessary. Next slide, please. Proposed resolution PEB 2024-03, amending resolution PEB 2021-04, resolving dual enrollment when an employee's only medical enrollment is in SEB. If the employee is enrolled only in PEB dental and PEB vision, and is also enrolled in SEB medical, and no action is taken to resolve their dual enrollment, the employee will remain in their SEB benefits and they will be auto disenrolled from the PEB dental plan and PEB vision plan in which they are enrolled. The employee's enrollments in PEB life, AD&D, and LTD will remain. The intention behind this resolution originally was to keep the subscriber where they were in medical. So in resolving the dual enrollment conflict, we didn't want them to lose that. And so that's what this achieves. We're just adding vision where necessary.
Can you, so what would be the scenario where this might happen?
Okay, so a scenario where this might happen is a employee who is PEB eligible and therefore has dental and vision has previously waived their PEB medical to be enrolled in SEB medical as a dependent under a SEB employee. Yeah, but they. Yeah, so that's how this would work out. And I also want to remind the board, the intent behind all of these resolutions originally was to resolve the dual enrollment situation on behalf of the employee if they didn't act themselves. We always give them the opportunity to resolve their dual enrollment first, if they end up in this kind of situation. If they don't do anything after we have communicated to them the need to do this, then these resolutions are what give us the authority to act on their behalf. Thank you. Next slide, please. I want to point out an error in this. I apologize to the board. The title for PEB 2021-05 should be Resolving Dual Enrollment Involving Dual Subscriber Eligibility. Unfortunately, this accidentally has the same title as the previous resolution. It is correct in the appendix, so please let the record reflect this, and it will be corrected in the slides provided when we ask you for these resolutions. Thankfully, the text of the amendment is correct, so I will read that now. If the employee is enrolled in PEB medical as an employee and is also enrolled in SEB medical as a school employee, and the employee has been enrolled in PEB benefits longer than they have been enrolled, or excuse me, I take that back. I misread. And the employee has been enrolled in SEB benefits longer than they have been enrolled in PEB benefits, but no action is taken by the employee to resolve their dual enrollment. They will remain in their SEB benefits and will be auto disenrolled from their PEB medical, PEB dental, and PEB vision plans. The employee's enrollments in PEB life, AD&D, and LTD will remain. If an employee is not enrolled in any medical, but is enrolled in PEB dental, PEB vision, SEB dental, and SEB vision, the employee will be kept in SEB benefits and auto disenrolled PEB benefits. The intention with this resolution was to prioritize longevity. So because they're enrolled in medical in both plans, we needed a way to determine which one we were going to keep them into. And so longevity is the one that wins out. And because this does get a little complicated when you take medical out of the picture, we have an example for you on the next slide. There is one more error that I needed to point out. So this should say proposed resolution PEB 2024-04. As Dave mentioned earlier, these do work in tandem with the SEB resolutions. So for every PEB, there's a SEB and vice versa. And sometimes when we make these slides, we copy and paste, and I did not catch this, so my apologies. But it will be reflected in the correctly in the vote slides. Okay, anyway, moving on with the example. Paolo has been a part-time nurse at Timberline High School since 2020. His wife works for Boeing, so he waived his SEB medical to enroll in medical under her plan. He is enrolled in SEB dental and SEB vision. In 2025, he gets a part-time job at Western State Hospital and is eligible for PEB benefits. He continues to work at Timberline High School. He waives PEB medical, but he does not correctly waive PEB dental and PEB vision. So he is defaulted into PEB dental and PEB vision, and now he is dual enrolled. Next slide, please. Paolo does not act in response to attempts from HCA asking him to affirmatively choose enrollment in either PEB or SEB plans. How does HCA resolve the school employees' dual enrollment? In this scenario, Paolo will be kept in SEB dental and SEB vision, and he will be auto disenrolled from PEB dental and PEB vision. This is happening because Paolo has been in SEB longer than he has been in PEB. I would like to point out to the board, this scenario is really unlikely to occur, however, it is possible. So in revising this resolution, we needed to account for the possibility that that would happen. Now, before I go on, are there any questions on how that works? Okay, thank you. Next slide, please. Proposed resolution PEB 2024-05, amending resolution PEB 2021-06, resolving dual enrollment involving a PEB dependent with multiple medical enrollments. If an employee's dependent is enrolled in any PEB benefits, and the dependent is also a SEB eligible school employee who is enrolled in SEB medical as a school employee, and no action is taken by either the employee or the dependent to resolve the dependent's dual enrollment, the dependent will remain in SEB benefits and will be auto disenrolled from the employee's PEB medical, dental, and or vision plans in which they're enrolled. This slide simply adds vision where necessary. Next slide. Proposed resolution PEB 2024-06, amending resolution PEB 2021-07, resolving dual enrollment involving a member with multiple medical enrollments as a dependent. If an employee's dependent is enrolled in both PEB medical and SEB medical as a dependent and has been enrolled in SEB benefits longer than they have been enrolled in PEB benefits, but no action is taken to resolve the dual enrollment, the dependent will remain in SEB benefits and will be auto disenrolled from the employee's PEB medical, dental, and or vision plans if they're enrolled. For the first paragraph of this resolution, we are simply adding PEB vision. If an employee's dependent is not enrolled in any medical, but is enrolled in both a PEB and SEB dental and or vision plan as a dependent, the dependent will be kept in SEB benefits and auto disenrolled from PEB benefits. The exception to this is if there is a national medical support order or a court order in place, in which case the enrollment will be in accordance with the order. This is similar to the slide I presented a couple of minutes ago, PEB 2021-05, where longevity is the rule, except this one deals with being enrolled as a dependent instead of as an employee. Are there any questions on this slide before I move forward? Okay, next slide, please. Proposed resolution PEB 2024-07, amending resolution PEB 2021-08, PEB benefit automatic enrollments when SEB benefits are auto disenrolled. If an employee's dependent, who is also a school employee, was auto disenrolled from their SEB dental and SEB vision as a result of SEB board resolution 2021-04, the employee's dependent will be automatically enrolled in the employee's PEB dental plan and PEB vision plan if they're not already enrolled. We have included SEB board resolution 2021-04 in the appendix for your review. Next slide, please. Proposed resolution PEB 2024-08, amending resolution PEB 2021-09, enrollment requirements when an employee loses dependent coverage in SEB benefits. If an employee who is eligible for the employer contribution toward PEB benefits was enrolled as a dependent in SEB benefits and is dropped by the SEB subscriber, HCA will notify the employee of their removal from the SEB subscriber's account and that they have experienced a special enrollment event. The employee will be required to return from leave status and elect PEB medical, PEB dental, and PEB vision. If the employee's employing agency does not receive the employee's required forms indicating their medical, dental, and vision elections within 60 days of the employee losing SEB benefits, they will be defaulted into employee-only PEB medical, PEB dental, and PEB vision.
With this resolution, we are adding PEB vision where necessary. We are also making a technical correction by removing the word school, which was erroneously included in the original resolution passed in 2021. Next slide, please. Proposed resolution PEB 2024-09, amending resolution PEB 2021-25, PEB continuation coverage eligibility for employees' dependents. If an employee's dependent was auto disenrolled from PEB dental and PEB vision because the employee was auto disenrolled from PEB benefits to remain in SEB benefits, the dependent may elect to enroll in PEB dental and PEB vision. These benefits will be provided for a maximum of 36 months on a self-pay basis. Next slide, please. And the final proposed resolution for today for the dual enrollment resolutions, PEB 2024-10, rescinding resolution PEB 2020-202, employees may waive enrollment in dental. The original text of PEB 2022-02 states, an employee who is eligible for the employer contribution toward PEB benefits and who waives enrollment in a PEB medical plan when they are enrolled in TRICARE, Medicare, or other employer-based group medical and are not enrolled in SEB medical may waive their PEB dental only if they are enrolled in both a SEB dental plan and SEB vision plan as a SEB eligible dependent. The reason we are recommending to the board that you rescind this policy is because now that PEB will have standalone vision, there is no reason for a PEB member to be able to do this. We originally passed this in 2022 after we realized that because SEB has standalone vision, we needed a way to enable a PEB employee who had waived all their medical for reasons that we allow them to other than enrolling in SEB medical to be enrolled as a dependent under a SEB employee and be enrolled in their dental and vision plan. But now that PEB will have standalone vision, there is no conceivable reason to do this, and that is why we were asking you to rescind this resolution. Before I hand it back over to Stella, does the board have any questions for anything that I have presented to them today?
Just gonna jump in and do a quick apology to the board. I think I had meant for the next presentation to be before this one to help give even more context to these dual enrollment resolutions. And so as a writer, that a lot of the changes that are in these dual enrollment resolutions are related to the fact to make sure that there were not instances where someone slipped through the cracks and ultimately lost some sort of coverage between the two programs. And the fact that there was this standalone vision in SEB, but it was embedded within PEB Medical, created extra wrinkles to make sure that somebody didn't lose out on coverage. Another theme, and this comes up quite a bit in this area, aren't the benefits exactly the same? Why would somebody want to be in one over the other? And they aren't currently actually the same. And they could have ended up for vision being diverging and having different benefit levels in 2025, but that was actually addressed in this most recent supplemental budget. But in the dental space, there is a slightly richer benefit in the SEB uniform dental plan compared to the PEB uniform dental plan. So there are some reasons that people may want to be able to be in one program or the other, but ultimately these resolutions and their whole were to make sure that if people didn't act and we want them to act, that there was a way for the agency to comply with state law and move people into account in a way that honored longevity or and made sure that there wasn't somehow a gap in coverage for somebody somewhere. So just wanted to kind of tick and tie that together and then say, hopefully, if you have more questions about these resolutions after Beth's presentation, happy to revisit in this meeting some of the ones. So that's my way of saying, Emily, don't leave the room after this presentation. Wait until after Beth.
Okay, and I would like to point out one more thing to the board. I did get ahead of myself on one of my slides. On slide 14, where we discuss proposed resolution PEB 2024-06, which amends resolution 2021-07, that involves the dependent member. I just wanted to make sure the board was aware, if a dependent being removed from PEB coverage loses dental or vision as a result of this resolution, what will happen is this will create what's called a special open enrollment event for the SEP employee under whom the dependent is enrolled in SEP medical to enroll the dependent in SEP dental or SEP vision should they so choose. And so this does not create a situation where a dependent would lose something, because on the other end of things, it would allow for that SEP employee to have a special open enrollment event, get them enrolled. And the other thing that I also wanted to point out, and hopefully this isn't too confusing, this is another one of those scenarios where it's not very likely to happen, but it is very possible for a dependent to be enrolled in dental in one program and vision in another program, as long as they're not dual enrolled in benefits across the board. And that could of course happen if one of their guardians was in PEB and the other one was in SEB. So I just wanted to make sure that I pointed those two things out. So thank you.
Does the dual enrollment for a dependent, is that like for prohibition still stand if the parents aren't legally like together? Like if you had parents that were divorced and had like a dependent child, but one worked for schools, one worked for a state?
Yes, it does. Yes. All right, thank you very much.
And this is the last proposed resolution for this presentation. Proposed resolution PEB 2024-11 amends resolution PEB 2022-04. Resolution PEB 2022-04 was adopted by the board in 2022 because federal Medicare rules require employers to offer employees over the age of 65 the same benefits under the plan and the same conditions as any other employee under age 65. Employees who are Medicare eligible must have the right to elect from the same coverage options as other employees under the Medicare secondary payer rules. We also take non-Medicare retirees into account, even though we haven't had an incident where a non-Medicare retiree questioned the PEB program's automatic deferral of PEB retiree insurance coverage when they became eligible for the employer contribution towards PEB benefits. This is how the program has administered the eligibility because there is no financial incentive for them to self-pay PEB retiree insurance coverage due to high premium costs. We recommend the board adopt this proposed resolution to include said benefits so the PEB program's practice of automatic deferral is uniformly applied so all employees are treated the same and in line with Medicare rules. And the proposed resolution reads, proposed resolution PEB 2024-11, amending PEB 2022-04, deferring PEB retiree insurance coverage when the subscriber becomes eligible for the employer contribution. PEB retiree insurance coverage will be automatically deferred when the subscriber becomes eligible for the employer contribution towards PEB or SEB benefits. The subscriber will be exempt from the deferral form requirement. Are there any questions from the board? None?
The requirement we just talked about, would that impact people who go back to work after retiring?
It will. If they're eligible for the employer contribution, then we will defer their PEB retiree insurance coverage automatically. So they will be enrolled in the PEB medical or SEP medical.
They won't have an option, but they will have a choice to pick which plan they want to be in, or will they just continue in the current plan?
They wouldn't be able to pick and choose whether they wanted to choose PEB retiree insurance coverage or choose SEP medical or PEB medical because of the Medicare secondary payer rules that we're trying to avoid having an issue. So that's why we're bringing this proposed resolution to the board for a vote at the next board meeting.
Okay, thank you.
Welcome. Any other questions?
The other piece to think about with this is when someone is bouncing in and out of retiree or employment status, without this addition on the SEB of recognizing the SEB side of the equation, someone could inadvertently potentially lose their eligibility and retiree coverage because they didn't turn in the form. And this is saying the left and the right hand of the healthcare authority of the York Division can see in the system that you're catching and releasing between the programs. And you're not going to be dinged because you didn't turn in a piece of paper as you were bouncing retiree employment status. We can't do that in every setting because we don't know all the employment statuses of everyone outside of the system, but we can do it within the two programs that we run. And this is just trying to make that what comes off to many as a bureaucratic process to maintain eligibility that is essentially eliminated in these instances. We talked before about why the deferral requirement exists and why that form exists, but this is just trying to soften some of the draconian efforts or impacts of that deferral form.
Any other questions from the board? So next slide, please. So this is the next step. We will incorporate any feedback from the board after the board meeting if the board member has any other questions. And we will incorporate your feedback in the proposed policy. And the public and stakeholders can submit feedback to HCA PEB SEP board policy feedback at hca.wa.gov by April 1st. And I will send out the proposed policy resolution slides to our stakeholders so they can provide feedback as needed. And we will bring back the recommended proposed policy resolutions for the board for an action at the next board meeting. Thank you very much.
Just as a comment, like I think the examples that you gave that weren't written down or just kind of the intent of it, I think that would be really helpful for when we build, kind of going off what Elliot said earlier around there's distrust. So when you see the like auto disenrolled, I think that could cause fears. Anything that we can say that make it clearer of the intent.
We'll try to go back to the original presentations. I believe we had, I remember very long examples and explanations in the original time as we were really trying to wrap our heads around this. If we could try to resurrect some of those in the appendix at least, so that there's additional context there.
Thank you.
Other questions or comments? All right, thank you. And Stella, I think you are staying for the next presentation. Emily, thank you. Except I think Dave asked you to stay in the room as well, so I appreciate that. Beth Eston and Stella are going to present, they're going to be presenting vision benefit changes occurring in the PEB program. The presentation will include resolutions and no action is scheduled on the resolutions today. There is materials are behind tab number 8. Beth?
Good morning, Chair McDermott. Oh, thank you, Dave. Good morning, Chair McDermott, members of the board. I'm Beth Heston. You usually see me in my role as procurement manager, but today I am for you as the vision account manager. And I do feel a little bit like I walked in after the punchline. I'm here to, next slide, please. I'm here to talk to you about the benefit changes, proposed benefit changes around vision having to do with employees and non-Medicare retirees in the PEB program. Also want to refresh everybody's memory about what is covered and discuss if action is taken on this proposal, how we will communicate with our members about it, and introduce actually Stella's going to introduce resolutions having to do with it. Next slide. I want to take the opportunity, first of all, to say that this change, as I said before, is only for employee and non-Medicare retirees. For their vision benefit, there will be no change to Medicare retiree benefits for PEB. Medicare retirees will continue to receive their vision benefit through their Medicare plan.
Or plans that have vision coverage, because a perennial question is, can Plan G have vision coverage? And the answer is no, because Plan G is regulated by CMS as to what it covers and doesn't cover. So yeah,
it is only a Medicare plan as opposed to a full.
So where there's vision coverage today in Medicare, it stays the same.
So as you know, The PEB program's been offering employee paid benefits since 1977. And the vision benefit has always been wrapped in to the PEB medical plans. Members might choose a self-insured PEB plan or a fully insured Kaiser plan, but their vision hardware benefit, as we call it, came through the medical plan. So part of the medical plan premium that's paid by the members went for that vision benefit, small fraction. In 2018, when HCA was ordered to create the groundwork for the School Employees Benefits Board, staff analyzed the existing school district insurance packages and discovered that most K-12 program portfolios, particularly the Washington Education Association portfolio, had a mandatory standalone vision benefit. To create less disruption to those members coming on, HCA procured 3 standalone vision plans for our SEB portfolio. And we also made it an employer paid benefit. 3 carriers were chosen, and they offer a choice of providers in as many counties as possible throughout the state. And since we hired them, they have worked hard to expand their number of providers and the number of counties that they cover. Next slide.
One more piece of context. In addition to trying to minimize some of the impacts that K-12 employees would have as they went into a consolidated program, the agency did also do the analysis of the kind of financial underpinnings of a standalone or embedded vision plan. If we had discovered that there was a significant financial savings or financial value to having it embedded in the medical plans, then we might have come to a different conclusion. But it dovetailed on the sub side with standalone also made more financial sense, which is what led us to a 5-year journey now of going at one day there's probably that same financial underpinning makes sense structurally, then we're going to want to address that in the PEB program. I just wanted to assure you that if the finances had looked the other way, then we might have had a different back in 2018.
What do you mean by standalone? I mean, you know what that means, but when I read it, I'm like,
Standalone means a vision plan that's offered by a carrier other than your medical provider. And so it means that a company, our companies are Davis Vision, IMED Vision, and MetLife Vision, will contract with a network of providers, and they will offer a benefit, in this case, identical to the benefit we're already offering, but members get a lot more choice about where they go. There are a lot more providers, particularly for folks who are enrolled in a fully insured product. As you know, when it's a Kaiser program, you can only go to Kaiser doctors. Well, that includes Kaiser eye doctors. With a standalone vision plan, they can go to a number of different providers in their area that aren't associated with one of the medical plan. So a lot more, there also are relationships with retailers that they have in these networks. And I'll cover that in slides, exactly. I'll name names in a few. So, all right. During the launch of SEB, we kept in mind these possible crossovers. And what we did was we created contracts in such a way that they could be leveraged to add on PEB without any need for a reprocurement. So we are coming to you, having been through a 23 legislative session where the state budget model assumed an employer paid benefit on the PEB program. And so we would like, beginning January of 2025, to offer the same vision benefit to our PEB members that we offer in the SEB program. The goal, of course, is to align ourselves for possible consolidation, and also to avoid having to go out on another procurement. So the alignment of the two portfolios looks very promising, and we would like to move forward. Next slide, please. I want to remind you, first of all, that there are medical benefits that will stay under medical. And those are the more serious eye-related conditions that have always been handled under a subscriber's medical benefit, treatment of infection or injury to the eye surgeries, monitoring and treatment of diseases like glaucoma, cataracts, diabetic retinopathy. Those conditions will continue to be covered under the medical plans that PEB members already have. They're covered under the SEB members' medical plans. Next slide. But on this standalone vision, what we will do is take out what we already offer for medical, a vision benefit. And that's a yearly routine eye exam for members. And then dependents under 19 receive a pair of glasses or contact lenses in lieu of glasses every year. For adults, $200 every 2 years, $200 every 2 years to be spent on a pair of glasses or contact lenses in lieu of frame and lenses. And this will start in 2025. The benefit had been $150, if you know. During the budgeting, we were given just this past year, we were given an extra $50, so it's going up. Also,
Beth, is there a difference in network and out of network?
yes, there will be a difference between in-network and out-of-network. And I have a slide that will show you the different costs in a moment. So, okay, the other thing that, beginning in 2025, we're going to align the two programs so that the 2-year benefit reset for adults is set in numerically odd years. So 2025, 2027, 2029. If you're hired in an even year, you get to double dip. And folks who, perhaps got their glasses this year under their medical plan will also get a new bite of the apple in 2025. Next slide.
Sorry. And so what I'm hearing is that if you enroll in 2026, you can double dip as well.
Yeah, if you are hired in 2026, you would be able to use your benefit immediately, and then it would reset in 2027. So, all right.
Just to highlight, we're proposing the same thing on the SEB side. Right now, SEB resets on even years and PEB resets on odd years. Another example of how people might want to benefit in one program over the other, and to eliminate some of that potential gamemanship and switching that can happen there. So this would align both programs to be on the same side.
All right, so here you have a chart in front of you that gives some of the advantages that arise from having a standalone vision plan. They offer a number of discounts on lens enhancements. And those of you that wear glasses know that this is where the nickel and diming begins. But what these plans have done is that they offer these discounts, and they also pre-negotiate co-pays for additional services. So you can see that while they don't line up exactly the same benefits across the board, each of them offers pretty significant discounts on some of the more popular of the enhancements to your lenses. Next slide.
So when you're saying that, are you saying that the discount in comparison to what we had before? Okay.
Yeah, some offices don't offer any discounts, and you pay for each enhancement. With the new plans, you'll have at least a guideline on how much the enhancements are going to cost you. And we have someone in-house who's very familiar with how this works for the provider. And she says that these are excellent discounts for the enhancements.
Can I rephrase back to what I think I'm hearing? So as a state employee right now, like I buy my glasses and I'm not getting a discount, because to me, when I look at this, I say, what's the benefit according to the cost of, I have to make one more choice. So the benefit being, okay, we're gonna give you more choices, but that means more likely than not, if you have eye care needs, that you're gonna have a greater discount in your overall cost.
Yes, because the discounts are pre-negotiated and set. They have deals with retailers and providers because of the network that we don't have access to under the medical benefit. So this would give a new pathway to reduce prices.
The other benefits, Skylar, are right now, the employees paying incremental 15% of the vision premium that's embedded in medical, and now the employer will pick up the full cost. So that's another benefit. Yes, you have to pick a choice, pick a plan, but you're not picking up 15% of the incremental cost. And that incremental cost for vision goes further, which is how you can use the same dollars to, as from our standpoint, to pre-negotiate these discounts, which gets you the better benefits. So the dollars that are spent are going further and being picked up fully by the employer.
So added choice and added value. All right. Pediatric dental coverage similarly comes with the pre-negotiated, or this is about the basics of coverage. And as you can see, $0 copay is repeated. The numbers that are in parentheses are for out of network. So we, of course, encourage members to find in-network providers, and there are plenty of in-network providers, except for counties where there are no providers, and we do have some of those. So we make it available to kids, and children's frames and lenses are covered at a usual and customary cost to reduce some overspending that went on when the ACA was originally put into place. There are some added costs for more complicated vision care, but medical necessity is also applied on a case-by-case basis for the kids' glasses. So anyone under 19 can get a functional pair of glasses for $0. Next slide. And this was a slide I got ahead of myself. As you can see, they get an even better deal on most lens enhancements. They're enhanced for $0. So, next slide. Now, I said earlier I would name names about retail locations. And as you can see, we have a lot of the biggies. And that means that these carriers, Davis Vision, iMed, MetLife, have arrangements with these retail locations to give these lower prices. And as some of you who are in fully insured or may have been in fully insured medical know, if you're in Kaiser, you can't go to Costco. As the Kaiser account manager, I get a lot of complaints. Why can't I just take my prescription and my $150 and go to Costco? It's out of network. In this case, Costco and Sam's Club are in network for at least two of our providers, and Target, LensCrafters, Pearl Vision, and others are also available and in network. Next slide.
Real quick, I also want to highlight on this, if we can go back up to slide 10 for a second. You see the phrase Davis Vision by MetLife. I just want to highlight, you're like, why is MetLife on the page twice? Well, we originally procured the benefits. Davis Vision was a standalone company. It comes as no shock to this board or anyone in the public that there's a lot of mergers and acquisitions that have happened every year. And an example is MetLife bought Davis Vision. There is a separate benefit design. They are, we're separate provider networks, and there's still some integrations that are going on as part of a merger and acquisition, but they are standalone benefits. But we're trying to have more, truth in advertising. It is a MetLife company, and it's still brought to you by MetLife, though it is the original name. So there are there are two versions of MetLife within our vision portfolio, or two ownership interests there. So just wanted to highlight what that meant.
Yeah, and to expand on what Dave said, Pursuant Health is the actual owner of Davis Vision. So MetLife bought Pursuant Health, so it's even more complicated. So I try to refer to them only by Davis Vision, just to keep it clear to our members, because the benefits are different, the networks are different, and the relationships that they have around discounts are different. Next slide. So if the board chooses to go forward with this proposal that staff has brought, we will begin a communications plan with a number of different audiences. First of all PEB program non-Medicare members. So non-Medicare active employees and non-Medicare retirees will also roll the communications out to our benefits administrators at each of the agencies and employer groups. We will, and we have already notified the medical carriers that we are going to carve out vision. We've notified the vision carriers that with the board's approval, we will begin to integrate them, and they will have to accept the other half of the PEBB population, which they are very happy to do and quite capable of. And then we'll also have to reach out to other stakeholders like labor coalitions and retirees associations. We don't want to surprise anybody with this change. And we want to make sure that they're getting clear messaging. So we've identified these audiences. Next slide. Sorry.
Couple questions. John?
I am curious, if you have a state employee or a retiree who's Medicare eligible, but not receiving health care through PEB right now, will they be eligible for the vision benefit, standalone vision benefit?
If they're not available, if they're not eligible for the employer contribution, no, they would not be eligible for the vision benefits.
In order to become eligible for the employer contribution, you'd have to be in the medical plan.
No, you'd have to be working for an agency or employer group.
It bootstraps back to the core eligibility of the PEB program. There's 6 or 7 ways you could be an elected official, you can be in higher education, but you have to be one of those core eligibilities over state agencies that's anticipated to work at least 6 months for 80 hours a month.
Yeah.
And for higher education, it's the 2-year averaging because of the quarter to quarter and semester schedule. But if you meet those core eligibilities, that's what says if you meet those, you get the employer contribution. And then you can waive medical or you can waive, but you would be eligible for these for dental and vision benefits.
What about if you're eligible for PEB benefits as a retiree, but you don't opt for them at the moment because your spouse, for instance, has coverage? Would you then be eligible for vision benefits, so to standalone?
If you were a dependent on your spouse's account, you would.
My spouse would, I'll use myself as an example. My spouse is not a state employee. She's retired from somewhere else. So we get our health care through her. But when I retire, I would be a PEB retiree, but I wouldn't probably be at this point. I may in the future be using PEB coverage. Would I be able to get vision as a standalone benefit?
So as a Medicare recipient, none of this impacts Medicare because that's embedded in your medical. So if you're a Medicare recipient and you're deferred your medical status, then you wouldn't have access to a vision benefit. If you're a non-Medicare, you actually have to be, this is one of the resolutions that Stella will go over, but currently, for example, you can't be in dental unless you're enrolled in medical. And so one of the resolutions Stella is going to bring is to say, and you can't be in vision unless you're.
I would have brought that up also, but I just, we're talking about vision.
Yeah.
So my concern is, so would that mean you could be eligible in the future?
No.
No.
No. That you'd have to be enrolled in PEB medical as a non-Medicare individual to be able to access the standalone vision benefit, just like you have to be today to access the dental benefit. And none of this applies to a Medicare retiree.
Okay, thank you.
I'm not sure, feel like I'm missing it and it's here somewhere, so sorry if you already said it, but, what if somebody misses the boat and just doesn't enroll? Cause they're thinking that, are they auto-enrolled into something?
They'll be folded into MetLife.
Hang in there, Stella has 5 resolutions on eligibility and enrollment processes.
And Kurt has.
And Kurt has a question. Kurt? You're on mute, sir. Which is a good thing most of the time.
I know, I'm
No,
trying to make sure I stay on mute, sorry.
he's not talking, it's a good thing to be on mute. Wow.
Thank you, so this,
Right there.
okay, so this question isn't specific to this agenda item, but I heard Beth mention potential consolidation of SEB and PEB. And I think we've all seen the proposals floating around the legislature, and so maybe this question can't be answered right now, but I would like at some point to discuss it and what the impacts of a possible consolidation would be to our PEB members, pros and cons, you know, what the impacts to both boards would be, et cetera.
Yeah,
Thank you.
We'll definitely talk more about that. Tanya's presentation about the budget, we're gonna talk about the budget, and there was a provision in there about another consolidation report. Will be at the April board meeting. I'd revise Beth's statement a little. There are a couple of reasons why having the benefits aligned. One was it would facilitate and make a consolidation easier in a future world. But it also, we often get questions about why does one populate, it's kind of an equity question. Why do certain populations get a benefit that other populations don't get? We get this question, I think I get it at least every month since in the last 5 years, as to why are there more sub-medical plans than there are PEB medical plans? Why can't a PEB active employee have access to a Premera medical plan like a school employee? And so the more the benefits are aligned, the more it avoids inequity questions that exist at least within the PEB and SEB population. I'd be remiss if I didn't point out, when we talk about equity at our agency, on the Medicaid side, there is no adult vision coverage within Medicaid. So we talk about a low, I've had glasses in hardware my entire life since I was 4. I appreciate the value of $1 but I know that $200 even in a better benefit in 2025 isn't enough to cover a lot of hardware. But it is certainly more than what happens in the non-existent today state in Medicaid, where after age, I believe it's 19, unless you're coming out of the foster system, there is not a hardware benefit. It can be added, and it has over the years waxed and waned in the Medicaid program as to whether there is vision hardware coverage in the Medicaid program. And so we look at a lot of different equity lenses. So that's the other reason that I think about this is having the portfolios have a similar or much more similar benefit helps address equity questions. It does also, if there was a consolidation, it's much easier to put 2 things that are more similar together than it is 2 things that are different. But we'll certainly talk about consolidation, that report, as the board season goes on.
Kurt, I think one thing that's gonna be interesting is that if consolidation does come from the legislature, it all depends on how they do it. And
Yeah.
And, it gets a little wild during session, right? Bills come in, we do our narrative, we do our fiscal notes, we send them back, they see something, they didn't realize they were breaking something or making something harder. So a lot of it is sort of in flight and will be in the moment. So it'll be hard to anticipate every possibility for what consolidation looks like.
Right, and to me, all the more reason to be educated fully about the impacts so we can help potentially steer them the correct way.
Understood. Ellie?
Yeah, one other thing, thank you for proposing to do a presentation on the proposed merger. I think it would help everyone to know how each proposal came about and them, and perhaps what their interests are in proposing these. Because I don't, at least one of the proposals does not come from HCA, from my understanding.
We'll certainly talk about, let's wait until the governor acts on the budget, and then we'll talk about what's in the budget. But yes, we'll cover stuff like that soon.
All right, so are there any more questions? So to continue, I just want to outline a communications plan that is that we're intending on having identified those important audiences we have, the ability now to, if this is voted for at the April 11th meeting, we will begin with an announcement to benefits administrators that it's coming. We are going to assemble an FAQ for our internal folks to answer questions. We will have an article in the May for your benefits newsletter. There will be announcements on the website, social media posts, and then as we move into summer, we're going to talk to the Labor Coalition about the change. We have intentions to send out postcards to members. There will be continued social media posts. Next slide. And in the fall, as we roll up to open enrollment, another letter in the For Your Benefits newsletter. We will have a forwardable message that benefits administrators and stakeholders can send to employees and stakeholders, another postcard directly to members, and of course, we will have benefit fairs where members can get face-to-face time with benefits specialists to help them choose. However, as Michael pointed out, some folks may not choose. So in December, we will send out a letter for folks who did not enroll to inform them that they've been put in the default plan and could offer them the right to appeal that. Next slide. Now with these proposed resolutions, I'm going to hand you back to Stella to go through them.
Thank you, Beth. May I ask a question before we go to that? Yes. It's, I have a two-part question. Will the SIP board need to have a resolution to approve these vendors for 2025? And will the PEB board also have to have a resolution like we typically do in June or July? A resolution, separate resolution to approve the vendors for 2025? Or are we assuming we're doing that in April?
Because the benefit is ultimately employer paid premium, the board doesn't set the premiums for employer paid benefits. So in this instance, you would authorize the benefit design, and then all the financing is done behind the scenes of the funding rate. And so there wouldn't be an annual vote on vision benefits, just like there's not an annual vote on dental benefits today. But it's a employer paid benefit. There's not a, when there's changes to the benefit design, we bring you changes to those. This would start to fall and look a lot more like dental, where if there is something that is benefit design related, we bring you those resolutions. Here, it's been a while since this has happened in the PEB program, but you're creating the initial structure of this benefit design, which is embodied in the charts that Beth just went over. The first resolution Stella's going to describe is the creation of the benefit. And then the premium is negotiated and set by the state, but as part of the funding rate model. None of that authority has ever come to the board because the board's authority goes on employee premiums, not employer. We bring, for example, we also bring you when there are changes in the employee paid life insurance and LTD, but we don't bring you changes when there's premium in the employer paid. We tell you about those changes, but there's not a decision for you to make when it comes to the employer paid, because the state, as the employer for the especially the PEB program, is deciding what it is funding on the employer side of the equation.
Is it conceivable the three vendors could change between now and July?
No.
Okay.
We did the procurement back in 2018 or 2019, selected those vendors, we're leveraging those contracts. We were telling the sub board about what's happening over here to give them context of the dual enrollment resolutions, but other than that, there's no normal course of business on the sub side. In fact, we don't even need to take the sub board the incremental increase from $150 to $200 because that was actually the way that the state is complying with the collective bargaining agreement. So the sub board doesn't actually have the ability to reject that change because it is how the state's complying with the CBA, and there's not a board relationship to that part of the equation. So there's really not even anything on the sub board's agenda related to changes in subvision.
I was gonna ask a question later on, but I'll just ask it now. So when we get to the resolution that designates Davis, MetLife, whatever, we don't have to be worried that, well, we're gonna have to come back in 2 months to amend it.
Correct.
Okay, thank you.
Stella.
Morning, Chair McDermott, members of the board. For the record, again, my name is Stella, Policy and Rules Coordinator from the Division. The previous policy and rules development presentation includes the board's authority statutes. They are placed in tab 7, slides 2 and 3 of the briefing book for your reference. So I won't be covering those in this presentation. Here are the 5 proposed policy resolutions that implement PEB vision. The first proposed resolution addresses the benefit designs of the fully insured vision plans, and the next 4 proposed resolution address enrollment policies. Our goal today, again, is to introduce these resolutions, get your insights, and incorporate feedback for the board to take action at the next April board meeting. Slide 17, please. Proposed resolution 2024-12, fully insured vision plan. And it reads, the benefit design for the embedded refraction vision exam and hardware coverage for employees and non-Medicare retirees included in prior board policy decisions and resolutions is rescinded and replaced with the following. Beginning January 1st, 2025, the PEB program will offer standalone fully insured vision plans by iMed Vision, Davis Vision, and MetLife Vision as presented at the March 21st, 2024 board meeting. Are there any questions?
Just highlight, sometimes we try to bring you the illustrative examples of everything that would be rescinded. And other times the ravages of time have made it quite hard to identify exactly where everything is. You might recognize or remember this language about prior board decisions and resolutions are rescinded. We did that same language in LTD when we weren't quite sure where the resolution were in the 70s. So it's just if somebody somehow came across something that's like, well, is this real or is that real? This just is trying to say repeal everything from the past, replace it, start fresh, reboot. Here we are.
John?
I'm wondering if we shouldn't say Davis Optical or Davis Vision by that one. Just so that later on someone reads this, they realize we knew.
I weighed that too, and I went to our contract, and our contract is with Davis Vision Incorporated. So that's why I didn't include Net Lights.
The next proposed resolution. Proposed resolution PEB 2024-13 addresses employees who are eligible for the PEB vision plan as of December 31st, 2024, and did not make an election during this annual open enrollment that will be auto-enrolled in a PEB vision plan effective January 1st, 2025. The dependents on the account will be enrolled in the same PEB vision plan as the subscriber. And the proposed resolution reads. Proposed resolution PEB 2024-13, default enrollment if an employee did not enroll in a PEB vision plan during the annual open enrollment in 2024. All employees who are eligible for the employer contribution towards PEB benefits as of December 31st, 2024, and did not make an election during an enrollment period established by the Healthcare Authority in 2024 will be auto-enrolled in a PEB vision plan as designated by the director or designee effective date of January 1st, 2025. Any dependents on the account that are enrolled in PEB Medical will be enrolled in the same PEB vision plan as the subscriber. Are there any questions before I move on to the next one?
I'll highlight on this one, when we have enrollment resolutions related to auto enrollment or default, we typically specifically have not identified the plan in the resolution. I can tell you on the sub side that the plan that is used for auto enrollment purposes is the MetLife Vision Plan, not Davis by MetLife, but the MetLife Vision Plan. It is the plan, one of the factors of whether it has the broadest network with the most providers in the most counties across the state. And I'll just also highlight that it, because people will often ask this, is the state picking the cheapest one? No, it's not the one that has the lowest admin or the lowest cost per month. So that's, you know, that's not the outcome here and would likely end up having the same unless there's some big shakeup in provider networks. Those are the type of factors that go into play.
So the third proposed resolution, PEB 2024-14, is a longstanding requirement for our retirees that they must enroll in medical to enroll in dental. With the implementation of PEB Vision, we are recommending the board to adopt this enrollment resolution for non-Medicare retirees. And it reads, proposed resolution, PEB 2024-14, non-Medicare retiree enrollment requirement. A non-Medicare retiree must enroll in medical to be able to enroll in dental, in vision, or in both dental and vision. Are there any questions from the board? Moving right along to the fourth proposed resolution, PEB 2024-15, amending resolution PEB 2021-12. In parentheses, amending resolution PEB 2020-04 relating to default enrollments for an employee who fails to make a timely election to include enrollment in employee-only vision coverage. I've placed the resolution PEB 2021-12 in the appendix for your reference. So this proposed resolution addresses default enrollment for a newly eligible employee or an employee who regains eligibility for the employer contribution towards PEB benefits and failed to make a timely election. And the proposed resolution reads, proposed resolution PEB 2024-15, amending PEB 2021-12. Parentheses, amending resolution PEB 2020-04 relating to default enrollment for an employee who fails to make a timely election. Amending PEB 2021-12 to read the default election for an eligible employee who fails to timely elect coverage will be as follows. Enrollment in employee-only medical coverage, enrollment in employee-only dental coverage, enrollment in employee-only vision coverage, enrollment in basic life insurance, enrollment in basic AD&D, enrollment in employer-paid long-term disability insurance, and enrollment in employee-paid long-term disability insurance at the 60% coverage level. Are there any questions from the board? And here is the last proposed resolution for implementing PEB vision. Proposed resolution PEB 2024-16, amending policy resolution error correction adopted on July 16, 2014. And I've placed the original board resolution adopted on July 16, 2014 in the appendix for your reference. And this proposed resolution amends the error correction resolution by including PEB vision. And it reads, proposed resolution PEB 2024-16, amending PEB policy resolution error correction adopted on July 16, 2014. If an employing agency fails to enroll an employee in benefits, medical, dental, and vision enrollment will be effective the first day of the month following the date the enrollment error is identified, unless the healthcare authority determines additional recourse is warranted. If the enrollment error is identified on the first day of the month, enrollment is effective that day. Are there any questions from the board?
Context, error correction is the concept that we use to describe what happens when a mistake is identified. And it really kind of sets the groundwork for what authority the home employer, or responsibility in some instances, the home employer has for a mistake that was made. So this is just incorporating that authority within the proposal. I'll also note this is an example of why it's so hard to find things from the past is with SEB, we determined that we needed a better tracking system and numbering system. So, before 2020, we had to figure out how to refer to things that were rescinding or amending. So, just recognizing how we've advanced on that process.
Well, if the board has no further questions, like slide 22, please. So the next steps will be the same as the previous presentation. We will incorporate any feedback from the board between now till the next board meeting. And the public and stakeholders can submit feedback to us at HCA, PEB board policy feedback at hca.wa.gov by April 1st. And we will bring the recommended board policy proposal to the board for an action at the April board meeting. Thank you very much for your time.
Thank you. Any additional questions? All right, we're gonna go ahead and take a little break. We're gonna set up for lunch. And we're having a working lunch. We're gonna be going over a smart health presentation. Why don't we get back at 12:50? Thank you. Here we go. Kristen's gonna, the wellness manager in her. Hey, everybody. We're gonna get rolling. Thank you. He is our wellness manager in the herb division and providing us some information on Smart Health, including an update on our transition from Limeade to WebMD. Welcome.
Okay. All right. Good afternoon, Chair McDermott and members of the PEB board. My name is Kristen Steinmanoff, as Chair McDermott said, and I'm glad to be with you today to share information about the transition of Smart Health from Limeade to WebMD. Next slide. So as of January 2nd, WebMD is the new Smart Health Center. Some key things have changed. We've shifted from the Limeade to the WebMD web-based platform. We've also shifted from the Limeade One to the WebMD Wellness at Your Side mobile app. And there are new features and new chances to qualify for the $125 wellness incentive. Some things are definitely staying the same. It's still Smart Health. You still get to it on the webpage from the same place, smarthealth.hca.wa.gov. And the name and the branding is still the same. So I'll show you in a moment, but the font, the colors, those things are the same. And there are still opportunities to earn points by completing activities and participating in challenges. Right. Before I move into talking about the new program, I'll briefly review PEB participation over the last 2 years. It was steady over the last 2 years. Over a third of registered eligible PEB participants participated in the program, completed the well-being assessment, and about a quarter qualified for the incentive. 37% engaged in Smart Health in some way, and satisfaction was positive. It was a little bit over 4 on a 5-point scale. Next slide. Yeah.
Of the 70, the registration numbers,
Yes.
is that equal to the 37%, or what percentage of the total?
I'll tell you exactly. Can you go back to the last slide? So in 2022, there were a little over 179,000 eligibles, and that 70,727 represents 39%. So 39% of eligible folks registered. So everything on this table is based on the registered. Yeah, and then in 2023, it was a little bit higher, 184-ish thousand eligible, 41% registered, that's not. So then, as I mentioned, all of the numbers on that slide are based on the register. So with the launch of the new program, it happened on the first business day of the year. And we sent out lots of communications on and before launch day. On January 2nd, there was an email to all employees who had signed up for communications through the PEB program or the SEB program. We also had sent an email to wellness coordinators and benefit administrators a week before, asking them to email their employees on or after launch day. And there was a home mailer that was sent out in late December. I got mine on January 5th, and that went to all eligible PEB and SEB subscribers. So as of March 1st, we have almost 13,000 PEB subscribers registered, and that's close to 8% of eligible PEB subscribers. And a little over 10,000 had completed the well-being assessment. WebMD is helping field calls and emails from folks, general questions about registration, incentives, username and password, and online tools with the program. So we're getting a lot of support from them there. Next slide. So these are the week by week trends, starting that first week in January through the end of February. We did have to start from zero with everybody in Smart Health because it was a brand new program. Everyone had to register from scratch with a new WebMD account. So registrations have been going up every week. We started with about 1,300 registrations and 870 well-being assessment completions in the first week. And now we're up to close to 13,000 registrations and over 10,000 well-being assessments to date. And this is in the PEB population. And the well-being assessments, it's about 80% of registered PEB users who completed their well-being assessment. And having that, first of all, it's a very high rate. If you compare it to 2022 and 2023, about 36% of registered folks had completed their well-being assessment. So 80% is showing we've got the really super engaged people in the program. But it's very positive because it gives people a more personalized experience, and I'll show you some of that soon. It unlocks additional features on the platform, and it's one of the things that's required to qualify for the wellness incentive. I think all of you have heard this before, but I'll just quickly review. For the wellness incentive, folks can get $125 as a reduction to their health insurance deductible, or if they have the consumer-directed health plan, it's a deposit to their health savings account if they do the well-being assessment and engage in enough activities to get to 2,000 points by their deadline. So when I keep saying incentive, that's what it is, and that's what people have to do. All right, next slide. So as I've mentioned, nearly 80% of PEB subscribers have completed the well-being assessment, registered in Smart Health have completed the well-being assessment. And so far, about a quarter have downloaded the app and are connecting to Smart Health from a mobile device. And I'll give you a little more detail about that at the end. There are more than 20 different trackers in the new program. People can use these trackers to keep an eye on their own behaviors, on certain screenings that are due, on different health status. And so far, we've got close to 20% of PEB participants using these. And about 8% each are connecting mobile devices, like personal health trackers through the Device Connection Center, and using the health record section to store or access information about procedures, immunizations, tests. So before launch, we did a preview webinar for all of our wellness coordinators and other agency wellness contacts like benefit administrators. And then after launch, on January 25th, we did a webinar that WebMD hosted, and it was open to all PEB and SEB employees. We had over 700 people join that. And I want to go through what we went through on that webinar and show you the overall employee experience. For one thing, because I want you to know what PEB employees have access to now. And also, the WebMD platform is more explicitly focused on managing health risks than the Limeade platform was. So I do want to show you some areas where the opportunities that I feel like we have to move the needle a little bit more on people's health behavior and health outcomes show up. Next slide. So now I'll start the walkthrough. As I mentioned, it's still called Smart Health, and if you're familiar with the program, some of this should look very familiar to you. When someone logs in for the first time, I've really blown up the menu bar options, but at the login, you see those 3 lines in the upper right-hand corner, and that's the main menu where people can click on that and explore all the different components of the program. But also, if they don't go to the main menu, they're automatically defaulted to the My Health section. And you see right under the logo, My Health is in blue. You can also see that the first thing that shows up if they haven't completed the well-being assessment yet is an encouragement to do that. So there's a box right at the beginning saying complete your well-being assessment, and under that, it has a little lock that shows you, you can unlock more once you complete your well-being assessment. Next slide. So once you've logged in, you're automatically taken to the top of that My Health page. You could choose to stay here or navigate over to activities and resources on the right-hand side under Smart Health. I'll stay here for now and go over there in a moment. But you can see at the very top, I logged in with a test user account. You see diabetes. This is information that's going to show up based on the topics the participant tells the system they're interested in. So in this case, diabetes was showing up for me based on some of the interests in my well-being assessment. And right below that, now it's showing the view if you've completed your well-being assessment. So I told you it unlocked some things. And one of the things is it shows very clearly your progress towards qualifying for your incentive. That was a little bit fuzzier to people in the previous platform, so I'm really glad that it's so explicit here. Next slide. Right below that, there's a daily habits feature, and in my test account, it's showing that I've caught up checking in on the work-life balance habit I'm trying to build. And below that is an example of the health trackers that I mentioned a minute ago. So this shows my exercise minutes have been updated, my steps have been updated, and if people sync a device, if people log in with a mobile device, this can happen automatically. So for me, these things are tracking automatically. Really great. And then at the very bottom of this slide, you can see other things to explore. It shows new ways to engage, it shows community. I can search for videos, podcasts, articles, all kinds of resources. Next slide. Before I move into the other section of the platform, I want to show you a snapshot of the well-being assessment results. So once you've taken the well-being assessment, there is a score and there's a risk report, and you can either download the risk report or it shows up on your Smart Health page, and it's organized into high, medium, and low risk areas with very specific suggestions for taking action to reduce your risk or keep up with the things that you are at low risk for. Next slide. So now going back to my home page, I'm going to toggle over to the activities and resources section. Again, that's right below the Smart Health logo. And the first thing you see on this page is core activities. And these are things that are available to all Smart Health users, regardless of what health plan they're in, regardless of whether they qualify for an incentive. All people who are using Smart Health can participate in any of these activities and get points for them. Below that, on the next slide, these are the benefit activities. These are very targeted. So what shows up will depend on what plans you're enrolled in or what PEB benefits you're receiving. So you can see that this test user has a Kaiser Permanente Washington account. They have MetLife Vision. They have Delta Care for their dental. And they can also see information about their MetLife insurance program. So we really use Smart Health. We leverage Smart Health to educate people about their benefits. So I like that we have all the benefit activities in one place. On the next slide, There's another view that shows it in a way I also really like. This is an opportunity to see all the different ways you can earn points. And if you look at the fourth one down, Kaiser Permanente Washington activities, you can see that so far I have earned 625 points of a total of 1325. So it tells me you've learned some things about your Kaiser Permanente Washington account, or you've done some things, you can do more and earn more points. So I really like this vision too. And then it has a table below that shows your completed activities, including the well-being assessment. It's just showing it in a really different way, but it shows you lots of opportunity. Next slide. There's lots more to explore, but I'm going to show you just two more features. The first is the content hub. And again, if you access that main menu from the upper right-hand corner, you choose content hub. And this is an ever-changing feed of information that is driven by the interests that you select and the issues that you note in your well-being assessment. Next slide. Finally, I would like to show you the community feature. This is something that existed several years ago in the Limeade Classic app in a different format, but it was a community feature where people could interact. And there are several different communities of interest, and it's getting a lot of participation. So it's nice to see people engaging in smart health, asking each other questions, commenting on their behaviors. The next slide gives just a little snapshot of sort of a conversation in the community feed. So you can see here people talking about pasta and running shoes, but there's lots of engagement. I check in on it several times a week, and it's neat to see what people are asking about and talking about and connecting about. Finally, on the next slide, there is a mobile app for everything that I've talked about today. It's available for Apple and Android devices. And so far it's been accessed by about over 3,000, PEB members. People can get a little bit confused here, so I just want to highlight this briefly. When folks go to look for the app, they're not looking for a smart health app, they're looking for wellness at your side. The app is called Wellness at Your Side. You can get to it through the Apple App Store or the Google Play Store. And once downloaded, in the middle of this slide, you can see there's a question to enter a connection code. And the connection code is Smart Health, all one word, not case sensitive. And then after that, they're asked to sign in with their company's SSO, and that is the Secure Access Washington sign-in, which lots of people are not huge fans of, but the SAW is here to stay, and we are still connecting to Smart Health and other things through SAW. So when you click on the connect through the company's SSO, that takes you immediately to the Secure Access Washington website, where you enter your credentials and then either sign up for the first time or go straight into Smart Health.
And
Next.
SSO is single sign-on.
Oh, sorry,
And that's what that acronym means. And since WebMD serves many employers and not all of them use something called SAW, ours single sign-on is called SAW. It's just the generic phrase that's used as the umbrella term for all the entities that are using the Wellness at Your Side app.
Next slide. Okay, there are a lot of resources available to help people learn about what Smart Health is and how to access it and how to qualify for the $125 wellness incentive. I realize there are a couple of PEBB resources here. The top one is, will issue a correction, but the top one is very easily changed by just changing the word SEB to PEB at the very end of the link. The fourth one, the incentive flyer, it's a different link, so we'll get that corrected for you. But all the rest are perfect for PEB subscribers, including links to an overview webinar, second to last, and that deep dive preview webinar at the very end. So if you have anyone, or if you yourselves are interested in learning more, really encourage you to check out these resources. That is all I have for you today, but very happy to take questions.
Any questions? So much. I appreciate your time today.
Sorry,
Oh, we do have a question.
I have a question.
No problem.
So, the usability. The extent to which there were discussions to help inform the development of components of that tool. To ensure that. So I asked this because I do this research actually, in digital healthcare management. One of the issues that came up for a lot of users, especially for tools that are designed for chronic disease management, is how intuitive it is to navigate that. And to go back to even understanding what their numbers mean for the wellness assessment. Making sense of that numbers and understanding how to move forward. And I know that the one thing that has come up in our work is that we need to talk to the community quite extensively to get a sense about not only their, but not even just literacy, but how easy it is to navigate school and to use the information in a user-friendly way, not even just user-friendly way, but in a way that benefits them personally. So I guess my question and all of that I'm saying is the extent to which there were those kind of discussion groups and with community members to inform their development.
It's a really good question. I'm trying to think of the best way to answer it. WebMD reviews everything with a clinical team, product team, a clinical team. They are a well-established brand, and they, when we were doing the procurement, they presented to us all of the features and the evidence. We did not have specific conversations with them about how are you getting this information to users. However, if we get feedback from people that something is confusing, something is inaccurate, we share that feedback with them right away, and they're very open and receptive to that, and they take it to their clinicians and they take it to their product team. So we're more on the, taking feedback and trying to get them to address it side, but we did not check on how this data was being shared on the front end.
Actually, I've thought about this. When we first established the wellness program, we brought in Limeade and we had a lot of discussion with the board, and there were questions like that, like how did they develop their product? How do they know it works? How do all these things? And so we definitely did that work in the beginning. And this time when we went out for the procurement, we threw the procurement out there. We said, these are the requirements, and WebMD was, successful, but we've never really come back to the board with WebMD and said, how do you do what you do? So that was kind of we did it way back when, but we haven't done it since. So maybe that's a good call out to have them come and explain their product and how they do the things that they do.
That'll be helpful. And the other thing that I'd like to add is what the literature is saying is that a substantial proportion of the population using, and these are chronic disease management tools, like diabetes and what have you, don't feel confident in using them in school. But when we create it, we feel that, well, it's doing what it's supposed to. So yeah, that additional follow-up to kind of get a sense as to what the population is saying. And certainly even additional testing, right? With them to see kind of monitoring whether it's meeting that benchmark that you set for yourself initially can also be quite beneficial.
Trying to figure out how to say this. Oftentimes in government, it feels like we buy, like we'll talk about, like we buy the basic car. We don't buy the upgraded car or like the luxury version of it.
You didn't want to call out a vehicle as being.
Yeah. But it feels, and that's my experience with Smart Health as well, as like someone who does have chronic conditions that like familial that I was born with, is this is not a helpful tool. This is a helpful tool for someone who might have developed that condition, and kind of the generic, hey, here's the advice on how to follow it is helpful. But so I think it's maybe if that's the case of like, hey, this is what we bought, and it's not meant to be customized care. It's meant to just say for the general group of people, this might be helpful information if you don't know anything about this. But if you actually have this condition, go see your healthcare provider. I think maybe that if that's the case, then maybe that's what needs to be clear of what this tool is useful for, versus what might feel kind of like false advertisement of this is gonna help you with your healthcare needs, which I don't think that's what this tool is.
It's not. I mean, I think that's all very fair commentary and really it's intended to help people improve their overall whole person well-being, physical, mental, financial, and work-life balance. So, there are a lot of resources, again, curated by WebMD clinicians on there. And they're also going back to a comment I made about leveraging the program to highlight our benefits. We have lots of information. And I myself as a consumer of our benefits have often learned a little bit more about things available and tried them out because we put a smart health tile on it and I thought, oh, I want to see what this is about. And so it can drive people in a lot of cases to resources that are intended to be treatment.
A
but
concrete,
smart health is not.
yeah, a concrete example of that would be your annual dental visit. What we discovered in the data was that if you don't go, you probably don't bring your kids. It's just one of those things. So, but if you do go, likely your kids will go. So we incentivized it in the platform to try and drive those numbers up. And we did have some success. It wasn't, we didn't go from 50% to 100, but we did drive the numbers up. So it is used to try and nudge people in different areas. Elliot, I know you had your button on. You've been very patient.
Actually, it's on a different question.
Been in the
Maybe
queue.
I should
You've been
get-
in the queue so
Maybe
long
I
that
should
you
get
forgot.
training on the, okay. Anyway, as I understand it, this program does not apply to retirees. It's only for actives. Okay, thank you.
If I may just add just one more thing. So we're moving towards this being a standalone. Tools, when I say standalone, to your point, that it is something that we hope that one day folks just pick it up and just do it, right, on their own. It tells them all that they need to do. It's prescriptive enough, but still allows a level of autonomy. But I think that in terms of the marketing that's discussed, to assure that folks understand that by itself, you're not gonna meet your full needs. That's certainly a discussion with your care provider or others can also supplement this tool. So that it limits the frustration that people feel that, oh, why is it that I can't do this on my own? Because it's a standalone, but we have to say it's not a standalone at this time. Certainly, we need to have you engage with your provider or whomever so that people don't have that level of frustration of not being able to just navigate on their own without that level of support, if that makes sense.
One thing I've seen, and I may, WebMD is such a common name and they have a lot of different products and a lot of different programs. And we market this really specifically, and I didn't talk a whole lot about it at the beginning, and I'm sorry for that. I might have helped by starting with a much more high level introduction. But we market this very much as the employee wellness program and try really hard not to market it as this is a solution to help you meet your healthcare needs. But I know that WebMD does have different products that do things like that. So there might, some people might get confused about it. So I think it's a good thing for me to keep in mind, but I also do want to make sure that the board knows this is not intended to be a standalone solution for meeting people's healthcare needs. It definitely is not that. I don't know if that was a part of, what you were thinking or not, but
That was what my thought was.
Okay.
That's very helpful here. Thank you so much.
Very.
Just real quick, I don't know if down the road there's a possibility, or maybe it's looked at before, but I wonder if there's a potential for doing something like a smart health light, pick a name, that would be available to retirees. And then if they wanted to get on to a full smart health, they could do it online themselves and buy in themselves, but just to have them access to something that WebMD might be willing to do gratis as a light version available to retirees. It's just down the road.
I would love that. I know, I was exploring the history of why retirees don't have access to it. And I know when the program was first introduced, the PEB board had a really deep discussion about it and how to set the eligibility criteria. And it was really connected to the governor's executive order around creating an employee wellness program and diabetes prevention and smoking cessation programs. And the healthcare authority suggested to the board that the population be employees and their covered spouses and state registered domestic partners. So, you know, the eligibility criteria was set way back in, I think, 2014. But if that were ever to be revisited by the PEB board, I think that would be a really interesting discussion.
There's also been a lot of scrutiny over the years on the funding of wellness programs in general, and Smart Health has not been immune to that. There was a period where a couple of years ago, we had quarterly reports to the legislature. We have a lot of reports to the legislature. They're usually not on a cadence of quarterly, but there was for Smart Health for about 2 years. And so there's also a lot of scrutiny that comes with funding of wellness and the very challenging return on investment question that pervades the space. Just another factor.
Other questions or comments? Thank you, thank you. Next up, Luke Dearden, clinical pharmacist in the Clinical Quality and Care Transformation Division, EQCT. Is joining us to talk about the Inflation Reduction Act, materials behind tab number 10. Welcome, Luke.
Good afternoon, Chair McDermott and members of the board. My name is Luke Dearden, as mentioned, and today we'll be discussing an update to an overview of the Inflation Reduction Act. Next slide. So really the goal of this presentation is to provide a really quick and high-level overview of the pharmacy provisions within the Inflation Reduction Act. The Inflation Reduction Act was massive and it did a lot of things, but this is going to focus on some of the pharmacy components. Next slide. So an overview of the Inflation Reduction Act. It was signed by President Biden in August of 2022. There are 4 main pharmacy provisions that I'm going to be focusing on. All of them really center around Medicare Part D. So number 1, it restructured the Medicare Part D benefit design. Number 2, it enables the federal government to negotiate drug prices with manufacturers. Number 3, it limits manufacturers' ability to increase drug prices at a higher rate than inflation. And then number 4, it caps the insulin cost share at $35 per month. And as I mentioned, these provisions impact PEB program members enrolled in a Part D plan. So next slide. So to further clarify that point, the IRA pharmacy provisions mainly apply to all Part D plans on the commercial market. PEB programs Part D offerings. So for example, the United Healthcare MAPD plan. The IRA pharmacy provisions do not apply to UMP Classic Medicare current pharmacy plan. However, it would apply to the proposed Part D option if adopted for 2025. And then it does not apply to the PEB program Medicare pharmacy plans with creditable drug coverage. For example, the Kaiser Permanente of the Northwest and Kaiser Permanente of Washington plans. Yes.
Does it apply to plans F and G?
No, because they don't have drug coverage in plans F and G. It's a good reminder. I'd say one of the top 5 FAQs that we get in the space is, can plans F and G be expanded to include vision coverage, hearing aid coverage, gym memberships, and prescription drugs? And the answer is no, 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 no to all 4 of those questions. Because, not because we like to say no, but because the structure of those plans is heavily regulated by CMS. And one of the hallmarks in trying to have standardization in an inherently unstandardized healthcare world. In the Medigap space for supplemental Medicare plans, they are heavily regulated so that wherever you are in the country, G means the same thing. And so it has a very specific benefit design. And so by nature, it does not have drug coverage, gym memberships, hearing aid, or vision hardware. And so these provisions wouldn't apply to an F or G.
Thank you, I always wondered that.
Yeah, thanks, Dave. Next slide. So the first, this is the first provision related to the Part D benefit design. The IRA restructured the Part D benefit design, which becomes fully effective in 2025. However, there was a smaller modification that started in 2024. To keep it high level, costs are basically shifted away from members. And an example of that is that the maximum out-of-pocket cost will be $2,000 starting in 2025 for Part B plans. It increases the responsibility of the drug manufacturer in the catastrophic coverage phase. So that's the phase after the member has met their out-of-pocket maximum. And then finally, it limits the base beneficiary premium increase to no more than 6% from the previous year. Next slide.
Real quick, I'll also highlight that this is a preview of coming attractions. Molly Christie has 2 or 3 slides in the next presentation about the phasing in and actually the phasing out of the donut hole, which is a question that we're getting a lot about, and how Part D benefit design was changed is directly related to that donut hole question, but hang on for dessert with Molly.
Yeah, definitely.
We're getting donuts, right?
We got rid of donuts. There's no donut holes, but there's donut holes over there. So, back to Luke.
All right, so the second major provision is the IRA requires the federal government to begin negotiating drug prices with drug manufacturers. And those first negotiated prices will first be effective in 2026. A drug eligible for negotiation cannot have generic availability, and it must have been FDA approved or on the market for at least 7 years for a traditional drug, and then 11 years for a biologic. One caveat of this is that drugs picked for negotiation must be covered by all Part E plans. And the table on the right-hand side of this slide shows the number of drugs eligible by year. So in 2026, there are 10 drugs that were eligible for negotiation or that could be picked for negotiation. 2027, 15, 2028, also 15. But at that time, it can also include Part B drugs. Part B drugs are provider administered products. And then 2029 and beyond, 20 drugs per year. Yeah, question?
Yeah, regarding the negotiation eligibility, so the at least 7 years since FDA approval or 11 years for biologics, what's the rationale behind that? And specifically, like, what's the impact to people with emerging drugs that might be really needed?
So you're asking what the rationale behind seven years. You may have to ask Congress that, but I would assume it's what they could get away with a significant pharmaceutical lobby. They don't want, for obvious reasons, they want pharmaceutical companies want a certain amount of time where their drug is not being negotiated. That would be my guess. But hopefully that answered your question.
And I think Tom has his hand up too.
Okay.
Yeah, I just want to make sure I clearly understand. So in 2026, there will be 10 drugs, and I think on your next slide, you indicate what those 10 drugs are. Then in 2027, they will add 5 more that's currently not on that list. In 2028, would those 5 drugs that were added in 2027 be the same, or is that an additional 5 drugs that would be added to the total? So in other words, the total number of drugs in 2028 would be 20?
No, it is my understanding that, so in 2026, there will be 10 drugs. In 2027, there will be an additional 15. And in 2028, there'll be an additional 15 after that.
So in 2028, then there would be a total of 40 drugs that would have the prices negotiated.
Yes, that's my understanding.
Okay, thank you.
Any other questions?
If some of those went generic, in the meantime, they could drop out, another one could be inserted, maybe, I don't know.
I don't know. I don't know if they can like backfill drugs that have gone generic.
No, I didn't mean backfill. I meant, okay, so say a drug in 2026, there was 10 of them that were selected. And then 2 years later, one of those 10 went, I guess you already answered it, went generic. Can they still get open? Then add an additional one to make up for the one that dropped out from the 2026 group. Not to go backwards and do it retroactive, but go moving forward.
No, I don't believe that's how it works. I think once a drug goes generic, it's, the generic price will be lower and plans will largely adopt the generic drug. But yeah, thanks for the question.
I think Harry's question is, can the slot be refilled? If there were 10 drugs, now one of them's generic, and now that slot, is it open? Can they add a new drug in the list in a future year? Or does the slot get lost to time, essentially?
Correct. Yeah, it's my understanding that the slot gets lost to time. As Dave put it.
I don't know how else to say it.
Maybe someday there'll be 0, so that would be good.
Yeah. All right, next slide. So these are the 10 drugs that were picked to be negotiated for plan year 2026. So you can see some pretty highly used products, especially in the Medicare population. Eliquis and Xarelto are anticoagulants. We have Jardiance, Januvia, and Farxiga are diabetes drugs. Entresto is a heart failure drug. Enbrel and Stelara are for a lot of different immunological type conditions, and Imbruvica is a cancer drug. And then the last one, the Fiasp/Novolog, is a short-acting insulin product. So all pretty highly used products. Next slide. So the third provision is drug price increase protection. This went into effect 2023, and it applies to Part D drugs and some Part B drugs. Basically, drug manufacturers will be required to pay the federal government for price increases above the rate of inflation. There has been some speculation here that manufacturers will just inflate the launch prices of the new drugs to kind of get around that in a way. But time will tell. It's a little too early to tell if that's happening or will happen.
You mean by launch price?
So by that I mean the initial price when a drug first comes out to the market.
Thank you.
Next slide. And then finally, this is one that definitely got a lot of media attention, but the IRA specified that there must be a maximum cost share of $35 per month for insulins for Medicare Part D members. This went into effect in 2023, so it's already in effect. I want to clarify that this did not necessarily lower the price of insulin. It just shifted the cost from the member to the payer in many ways. And not related to the Inflation Reduction Act, PEB members already experience a maximum of $35 per month on insulin, and that's due to Washington state law. And that's, next slide is the question slide, so I'm happy to take any questions.
Luke, you or maybe David, know the rationale behind the federal government's refusal to let organizations like the PEB board have vision, separate standalone vision and dental plans that they can offer retirees in conjunction with the Part G or Part F, I'm sorry, Plan G, Plan F, Medicare supplements. Do you know the rationale behind that?
I don't think we know the exact rationale. We can definitely look back a little bit. One of the things that I'm thinking about is, I can't remember the order that the plans came out. I don't know. I'm curious if Ellen might have any initial insights. We'll take that one back.
Yeah, maybe
If even Ellen doesn't have initial insights, we'll take that one back.
It seems to me that it would be a good thing, and I don't understand why they would have prohibited state retirees from having that benefit.
I think that's the federal government.
I bet them head on.
My best kind of initial guess is, as you're building a program, there are pieces that have enough political support to pass, and then you're bolting on to that original structure. I mean, our entire national health insurance infrastructure is built off of the concept of employer-sponsored insurance from many decades ago. And it's all built from that foundation, and you're always bolting things on to that structure as to whatever makes sense at that moment with what the Frankenstein's monster looks like and can be built onto that, infrastructure. The same thing happens in state law all the time. It's like, well, this is the next incremental step that can be made. And people go, why was it done in that way? Well, that was what could pass and what had enough votes and what made sense with whatever was happening in those days to get to that world. So
It's not a huge stretch. I mean, you just have to go across the street.
Right.
To buy your Part D. Or buy a vision plan. Go have the Washington State Employees Association provide that vision plan or the dental plan.
Yeah.
John, I think that's really part of the answer is that there are other avenues and there's not a pressure on Congress to do this because the business community is putting it through their lobbies because there's not that great a demand like pharmaceuticals. Glasses, a lot of us don't really wear them. Reading glasses, hearing aids, a lot of them don't wear. So, but everybody takes some.
Well, I'm thinking about Part D is,
I know, everybody
can't
takes
offer the Part D. Elliot?
I don't think there was among that's a focus on what the state plans were doing. I think you're right. That what happened in post-World War II, God, I go back a long ways. It was the employer plans that built pension contributions. You had big employers and they had healthcare plans. And Dave's right, that had political support. And nothing was added, and then times changed, and even currently, there is not political support for adding I'm not calling it this, but the word is entitlements. They're branding them as entitlements and that kind of thing.
Well, and John, you can get into even a more specific example, even under the Inflation Reduction Act. The fact that only Medicare plans can benefit from the price negotiations. There was a version in the US Senate that would have applied that entire concept to the entire commercial market. But what was able to pass Congress was a piece that addressed Medicare. And there's even, political commentary about a potential expansion of the Inflation Reduction Act to broader commercial on this exact point as to, well, why was it narrowed that way? That's what could make it through the process last year in 2020.
Other questions or comments for Luke? Luke, thank you. I think you're staying with us here for this next one. We have, we got a big one coming up here. Ellen, come on up. We've got Ellen, retiree benefits manager, in the IRF division. We got Molly Christie, fiscal analyst in our financial services division. Luke is still with us, and Stella is going to be coming back. And they're coming together today to present some more information regarding the 2025 UMP Medicare plan option that we talked about at the February retreat. Proposed resolutions are included in the presentation. No action is scheduled for today. Materials are behind tab number 11. Welcome, folks. We need another mic, or they're gonna share. Y'all are gonna share on the end? Okay.
Good afternoon, Chair McDermott, members of the board. Thank you. I'm Ellen Wolfhagen, the retiree benefits manager. And we are going to talk today on part of a quartet on presenting the 2025 UMP Classic Medicare Part D plan option. Next slide, please. So today we're going to talk about communications. Molly's going to give financial insights. Luke is going to give some more information about the benefit design, and then we will transition to resolutions, and Stella and I are going to do a duet part and talk through that. Next slide, please. So we have been very actively listening to retirees about their concerns and questions about the option to convert to a Part D plan. And we have changed our frequently asked questions on the website. We provided a quick facts sheet that outlines what remains the same, because there's a tremendous amount that is the same under the Part D. What changes are potentially going to happen, and then some of the most common drugs and copays.
And a copy of that for those in person is in the back pocket of your binder. Put a copy of that there. And for those board members on the phone, we'll add it as a follow-up.
We also conducted a number of town halls. So we did 3 initially virtually, and then added a 4th session. And our overall attendance was over 200 people. And the feedback was very positive. I have to say it was overwhelmingly positive. We heard from lots and lots of people. And one of the things that we also did that's not mentioned on the slide is I had done a webinar presentation, and my slides were available for view. And that was sort of the homework that we asked people to look at that before they came to the town halls. And we got a lot of very good feedback on that as well. So people really are hungry for information. We presented it in a way that they could digest it, if you will. And the feedback has been very positive. We also updated our retiree engagement page, and that page is meant to be a sort of living document. So periodically, every couple of months, I look at it, decide what things have to be moved around. We have frequently asked questions, we have Medicare myths, and we try to perk up the most commonly asked questions to the top. Next slide, please. So again, the themes that we heard, there was a lot of support for transition to Part D plan. The idea that this change would be the most immediate and have the biggest immediate impact on reducing premiums was very well received. As I said, the presentation materials were easy to follow. And some of the questions that we heard were, do we have to pay for Part D separately? And the answer is no, that would be included in the premium for UMP Classic Medicare Part D, ... we also heard, can you explain the donut hole? And Molly's going to go through a big presentation on that. And we were asked, how will members know about the impact if there's a change for drugs that they're currently taking? And Luke is going to talk about that. And then if we can't use manufacturers' coupons, so this is something that is a factor in Part D plans. Manufacturer coupons are prohibited from being used along with a Part D plan. Will that increase in cost wipe out premium savings? And our general answer is no, we don't expect that. The premium savings would be significant, and the increase in copays that people might have to pay would be probably around the range of half of the premium increase. I guess it would depend if somebody had many drugs that were higher, then that might be an issue. So Molly.
Yeah.
Thank you.
Thank you. So I'm Molly Christie. I work in our herb finance section. And in the next few slides, I'll touch on refinements that we've made to the original savings estimates for UMP with Part D coverage that were in the legislative report that I presented on at the last meeting. And then I will provide follow-up on questions around the Part D donut hole. So since our last meeting, we have made a few updates to the assumptions that were behind the original estimate in the legislative report for UMP with Part D coverage. These include things like past rebate projections. So we update our rebate projections twice per year. And so for this most recent refinement, we updated based on almost a full year of projections. And then we updated the actual enrollment results for 2024, which we have now, the MOTA Part D formulary and benefit design, which Luke has shared with you, and he'll be bringing more information on that after this portion of the presentation. And then I also included the MOTA administrative fees. So some of the pieces, not all of the pieces yet, but I can say that based on these refinements, the interim, calling these the interim premium savings, the original, the interim, and then we'll have the final, are still in line with what I presented at the last meeting. So as I shared in February, we're still expecting significant savings compared to what the 2025 rates could be, or what we would expect that they would be without this change. The final rates will still be available on the usual timeline. So that is May, June. I typically will come and present Medicare rates in an executive session in May, and then those will become public in June, and then either voted on at the end of June or early July. And unfortunately, this timeline is just not flexible because there are some really critical pieces to rate development that we have to wait for. One of those is claims runout. So we have to wait several months into the next year to have full claims for the prior year. Medical and pharmacy trend updates. So I did say we updated the pharmacy trend, but we actually have another trend update that we're waiting on. So we'll update that again. And then any plan design changes that could be on the medical side if we're, let's say, enhancing a benefit or changing a benefit for Medicare and non-Medicare UMP, that would be built in. We're also waiting on final federal guidance. We have the initial federal guidance, so we're pretty sure we know what things are going to look like for Part D, but we just have to wait for CMS to say, to put the stamp of approval and say this is what we're moving forward with. So switching gears, the remainder of the financial portion of this quartet today, we'll discuss the follow-up on that donut hole question. So the Medicare Part D standard benefit phases, and specifically the donut hole, the coverage gap, there are a lot of terms for it. This was, the donut hole, as it's referred to today, was a gap in coverage under the historical Part D benefit, where enrollees paid 100% of drug costs. So when I say historical, I mean back in like 2006, when Part D was introduced, there was a donut, there was a hole in coverage, where at the time, you know, a beneficiary would pay their deductible, they would pay 100% of cost in the deductible phase. Then they would reach the initial coverage phase, where they would pay the plan's co-insurance, they would pay the co-pay, whatever the plan had established within the limits established by Part D. And then they would reach the gap. If they used enough drugs and met a limit, a spending limit, they would reach the donut. And in that phase, they had essentially no coverage. And as they built up costs in the donut hole, they may reach the catastrophic phase of coverage where their costs were so high that then CMS comes in and says, we're gonna pay 95% of your pharmacy claims and you'll pay 5%. And that was obviously problematic for a lot of people, especially people that, used more of their prescription drug benefit. And there were changes that were made in the subsequent years to try and address this. So I'll go into those next. So the Affordable Care Act gradually reduced enrollee cost sharing in the coverage gap phase between 2011 and 2019. And there was some nuance there, so it affected like brand drugs and generic drugs a little bit differently. But as of 2020, the donut hole closed for all drugs. So for brands and generics, what that means is that members were not paying more in their cost share when they reached the gap phase than they were paying in the initial coverage phase. There were still some things going on in the background in terms of that other percentage that was covered either by the plan or by drug manufacturers, and that kind of changed over time, as well as those specific spending limits that got you to the next phase of coverage. Those are updated every year. So in 2024, the graphic shows the 2024 Part D standard benefit design. And you can see here that after a beneficiary meets the deductible where they're paying 100%, they enter the initial coverage phase where they're paying 25% for the cost of drugs, brands and generics. And then once they reach the coverage gap phase based on spending, they're still paying 25%. So for a beneficiary, it doesn't really, you don't necessarily know that you've reached the coverage gap because there's no difference in your cost sharing necessarily, but there are some differences going on in the background, and you might also get communications from your health plan saying you're in the coverage gap, which is a little scary because you're like, well, what does that mean? What's covered? And it doesn't really make a difference on the beneficiary side. On the plan side, they get a little bit of a break because for brand drugs in the coverage gap, manufacturers actually pick up some of the cost, about 70%. So it's a big impact there. And it also actually helps members reach the catastrophic phase where they're paying even less for drugs because the value of those manufacturer discounts actually count toward their true out-of-pocket expense, which is set at $8,000. So what a member pays or a beneficiary pays in cost sharing deductible counts towards that $8,000 as well as the value of the manufacturer discounts. And then once they reach the catastrophic phase, for the beneficiary, it looks the same as it did in the past where they pay 5%. And then now plans pick up 15% and the remainder is paid by the federal government. Yep.
Am I correct that this would not apply to F and G?
This is just Part D. Yep. So this is just prescription drug coverage.
Okay, thank you.
Can I just make a clarification? If you are on Plan F or Plan G, you most likely also have a Part D plan. So yes, it would apply to those people, not as part of Plan F or G. However, it would apply to their Part D plan.
So even if it's a commercial, I'm having
Yes,
trouble.
whether
wrapping
it's
my brain.
commercial or an employer group waiver like we have, it
Yeah.
doesn't matter. If Part D, it applies.
Thank you very much.
No, that's great. Thank you. So under the IRA, as Luke talked about, there were additional changes to the standard benefit coverage phases for 2025 that has effectively completely eliminated the coverage gap phase. So as you see here, after a member meets their deductible, they enter the standard coverage phase where they paid 25%. And then once they reach $2,000 in out-of-pocket spending, they are at the max and they don't pay anything else for covered drugs. They have no co-insurance, no copay. And then where a lot of the changes are, this $2,000 maximum out of pocket is probably the biggest piece. And then there are a lot of changes to the standard benefit that shift costs from CMS to plans. And you see that in the catastrophic phase where for generics, you have plans now picking up 60% of the costs as opposed to 15% in 2024. And then CMS is paying 40%. And then for brands, they're still requiring that manufacturers pay some of the share of that. And I think it's important to note here, whenever I talk about this standard benefit, this is really what CMS is setting as like the maximum that you can charge enrollees in a Part D plan. But plans, the pharmacy benefit managers or the carriers can choose to offer an alternative design that has lower cost sharing, that is enhanced over the standard benefit. So everything that we're talking about with UMP Part D would be considered an enhanced benefit, where a member is not gonna pay a 25% coinsurance. For the most part, they're gonna pay significantly less than that, but they are still able to have that $2,000 maximum out of pocket, which is the current benefit today under credit coverage. So that is not changing. Yeah.
Is there any speculation similar to what you were mentioning earlier, Luke, around in the catastrophic phase when the drug manufacturer is picking up another 20%, that they're just gonna roll that into kind of future costs?
Yeah, there is. So CMS is making some changes to the direct subsidy that should kind of net out. So there will be increased costs to the plans because they're paying more for claims, right? And that rolls into premiums. But they should get a larger direct subsidy, partly because the subsidy is benchmarked off of like an average, a national average, and if the average goes up, the subsidy goes up. So the math is a little bit confusing on it, but the expectation is that overall plans revenue from CMS for Part D should net out despite those changes. So to wrap up the donut hole topic, this is a holeless donut, or I don't know,
We'll call it
it's
cookie.
candy filled, it's a
Cookie.
cookie, it's a frosted beignet, it's something. It's a pastry that has no hole.
It's like an eyeball.
And so this just illustrates again that the coverage gap phase, the donut hole is eliminated. Completely in 2025, there is no more reference to a coverage gap. So you pay the deductible, you enter the standard coverage phase, you pay your copay, you pay your coinsurance. Once you meet $2,000, you're done. And then there are a bunch of other people paying your claims. So hopefully that brings a little bit of clarity to that question, and I'm open to answer any questions about it.
It might be helpful in a future presentation. I know how much money is before you get to the catastrophic stage. How much money do you have to pay out before you get to the standard coverage phase? I'm having trouble saying.
Yeah,
Just
so
examples or something, because I remember in another PEB presentation, they had what the amount was, the amount of, that you paid.
definitely. And for the standard benefit, it changes every year. For UMP, the deductible will be different than the standard benefit deductible. And then the $2,000 is the cap for everybody, and that's when you reach the catastrophic phase. I think our pharmacy deductible is $100, so if you can correct me if I'm wrong.
Correct.
Yeah, that's correct.
Good dramatic pause.
I had to think for a little bit.
Thank you for your question.
All right, next slide, and the next slide after that. So for the record, this is Luke Dearden again, I'm pharmacist with the team. To continue on with this presentation, I just wanted to provide a little refresher on what the cost share structure would look like on the Part D option compared to the current UMP cost share structure today. So again, and I presented this at the last PEB meeting or the retreat, you'll see that most generic medications would be available at $0 per 30-day supply under the Part D option. Additionally, preferred brands would be available at $40 per 30 days compared to $75 per 30 days under UMP. And again, all of those drugs all of those drugs that I presented during my last presentation a couple of minutes ago that are eligible for negotiation in 2026, those are examples of preferred brand drugs. So those are just some examples. And then finally, members will have to pay about $15 more per month for specialty medications under the Part D option. Next slide.
But generally, the percentage of prescriptions or members that are having specialty drugs is that percentage that we've talked about before. Do you have that off the top of your head by chance?
It's in the range of 2 to 3% of current Medicare members are taking a specialty drug.
And most aren't taking more than 1 or 2.
Correct, yeah. So during our town hall events that Ellen mentioned, we received some questions on if a 90-day supply would still be available through the Part D option because we had previously only presented on a 30-day supply. However, I want to confirm that 90-day supplies will be covered under the Part D option. In fact, you may notice from this table that there's an incentive in many cases to fill a 90-day supply where the cost share will only be double a 30-day supply, whereas under UMP today, the cost share is triple a 30-day supply. So where this really stands out, in my opinion, is the preferred brand tier, where for preferred brands, members would pay $80 per 90 days for preferred brands under the Part D option, and up to $225 currently under UMP for a 90-day supply. Yeah, question.
Where do opioids fall into that 90-day kind of incentive?
Yeah, that's a good question. So I'd have to get back to you on how opioids would be covered under Part D. Under UMP currently, we have a policy or criteria that kind of governs the use of opioids. And generally speaking, you're only allowed to fill a 30-day maximum at a time for opioids. And it's been a while since I've taken the pharmacy law exam and dispensed opioids at like Rite Aid or something. But it may be that you can only fill a maximum of 30-day supply for opioids, like by state law. But I can follow up on that.
Okay, I had a question, for down the road, the high cost generics and the preferred brand where you show 30% up to 225. Would it be possible to go back to claims history and find out what that number on average would be so that we would know that it was less than 20 or some not greater than 20 on average or greater than 80? Give us some sense.
I see. Yeah, so I can make a comment kind of off the cuff on that. Dave, maybe, well, I guess we'll see.
I know we've done some else, so it's not truly off the cuff, so I'm not panicking.
Yeah, so that's a good question for high cost generics. And we could follow up on that because the price variability with the high cost generics is quite large. However, because UMP's benefit is quite generous right now, and for preferred brands, the maximum cost is $75 per 30-day supply, or $225 per 90-day supply. I would say that by far most members are meeting that cost share cap for preferred generics, or sorry, preferred brands right now. By far most of them. Does that answer your question?
Yeah, I wouldn't want to come back on this down the road and find out that we got 1,000 people standing outside saying you got paying 80 now, we're gonna pay 20. But I don't know what you know, the history shows, what the actual claims would show that to be on average. If it's greater than $80, sounds like a winner. But if it's actually only 30 or 40, then it doesn't sound like a. But here it looks great, but in
Right.
actuality, it might not be. That
Yeah,
makes sense.
it totally makes sense. For preferred brands, it's almost certain that current members are paying quite a bit more than $80 per 90-day supply for a preferred brand product.
And just a reminder, we took the last column off of these because we were getting people who were more confused by it, by seeing it in isolation. But roughly the amount of prescriptions in the plan that falls under that row for brands is around 6%. And so Luke's describing the effects within that subset. The vast majority, over 90% of prescriptions, were falling in those first two rows, where the out-of-pocket cost is the same or better under Part D. This is the line where it depends, but most people are coming out ahead. And Harry, there will be some people, just as there were in the value formulary changes, that said, I paid 25 cents before, now I'm paying $5. And will say, yes, that is true. Also, don't forget to net out the hundreds of dollars less per month of premium that you're paying as well. And most people are going to come out ahead, even if at the point of a fill, there are certain drugs where they pay a little more in that instance. So we will be in a general reminder for folks to not forget about the premium decrease that they're seeing associated with that. But there will be some people who, on specific drugs, pay a little bit more.
Yeah, definitely. Thank you for that clarification. Next slide.
John, do you have?
Actually, I had a question. Who will be managing Part D? Will it be MODA, Regents?
Correct. Yeah, I have a slide on that, but yeah, correct. MODA will be and the benefit administrator for this Part D plan.
Elliot?
I have two questions. In the 90-day supply comparison, where do drugs that don't have a generic equivalent fall in? Are they preferred? They're not preferred brands, but would they be non-preferred brands? Would they be a non-preferred specialty?
So actually, a brand that does not have a generic equivalent, if it's preferred, would fall under the preferred brand here. And an example of that would be Eliquis. It's an anticoagulant. It's the top used preferred brand product in the Medicare population. And I believe something, last I checked, in the range of 4,000 to 5,000 current UMP Medicare members are using that product. It's also possible that a drug like that could fall into the non-preferred brand. It's also, if it's a specialty drug, a lot of specialty drugs don't have generics, so it could fall into that category as well.
Okay, so is cost the issue, or why is something preferred? I guess, how do you define preferred? I think Ellen did go into this before, but I don't remember.
So Yeah, I actually anticipated that you were gonna ask that. So, I have from our COC, basically.
Well,
No, I didn't mean it.
we've done time preparing. What are logical questions that might come up? So it wasn't like Elliott's gonna ask. It was like, this question could come up. So just refining the word you that was just used.
Yeah, yeah, I didn't mean it.
Yeah,
for
y'all,
better.
we were thinking about y'all's question.
Yeah, so, basically, preferred drugs are, well, drugs are reviewed by something called a Pharmacy and Therapeutics Committee. And that's a committee made up of, pharmacists and also providers like doctors or possibly like a, nurse practitioner would be considered in that group as well. So medications are reviewed by a P&T committee, and they provide recommendations to HCA and the plan on, you know, what may be preferred or not preferred. And then the plan reviews the P&T committee recommendations and determines which medications will be preferred on the drug list. And maybe to clear up a little bit of, just to clarify from your original question, a brand product that has a generic alternative, as soon as that generic comes onto the market, that brand product becomes non-preferred automatically because there's a cheaper generic, basically equivalent product that comes to the market. And then typically almost always that generic that comes to the market will be in one of those first three rows. So either the value, but more commonly either a preferred generic or a higher cost generic.
Then I have a second question. Maybe you thought of this one too. It's escaping. Oh, yeah. The other thing I notice is when you say something is a, what did you call it, an addictive, or what do you call those? Opioids, thanks. But that's classified too. There are all these different tiers of what is a, do you know what I'm thinking? You probably do, Mr. Short.
We didn't think of this question, so keep going.
Like class 2, class 3.
Yeah, you know what
Oh, the tiering structure of a.
Are you talking about,
yeah.
like DEA schedule?
Yeah.
Yeah, well, even in I work for the Department of Health, okay, I can't help. So you look at these statutes and regs, and they would have a tier of the level of
Controlled substance tiers.
Substance, yeah, so that has nothing to do with formulary tiers. That's,
Okay, that's something different.
that's the level of risk in a way, or a level of risk associated with dependency and stuff like that for medications. Typically, opioids are going to be control substances number 2, and then illicit drugs that are not really available by prescription, they would be the highest level or control substance number 1. Does that clear up?
So I was talking, so tier means a different thing in this context, is what you're saying. Okay,
Correct,
Got
yeah.
it. Thank you.
And Tom, you've been patiently waiting. We do see.
Thanks. Luke, I wonder if maybe for our April meeting, I think sometimes if I can visually see a name associated with something, it helps give me a better idea. So could you maybe give us a couple of examples? You don't have to do them now, but for our April meeting, a couple of examples of a preferred brand, a non-preferred brand, a preferred specialty, and a non-preferred specialty, and maybe speak to a little bit of how they end up in that different classification?
Yeah, that sounds good.
That's it. Thank you.
All right, next slide. So at the retreat, we presented that while the vast majority of members would be able to continue all of their medications under this Part D option, a small number of members may still require a switch to a therapeutic alternative. And to remind everybody, a therapeutic alternative is a drug that's not chemically identical to the requested product, but has similar safety and effectiveness. So these members who will be impacted will receive personalized outreach, not once, but twice. And so before January 1st, or the proposed go live date, impacted members will receive a letter to facilitate continuity of care. This letter, as an example, will include the medication they're currently taking that may not be covered under the Part D option, therapeutic alternatives that are covered, steps to obtain a new prescription from their prescriber, and steps to request an exception if necessary. Then after January 1st, 2025, all impacted members will automatically receive up to a 30-day supply of their non-covered medication. That's called a transition fill, as long as it's within the first 90 days of their enrollment. And that will trigger another outreach to the member, basically notifying them that they may need to switch to a therapeutic alternative.
Quick ask, when you do that personalized outreach, can you not send it around open enrollment time? Just because there's a lot, like, I don't even read half the stuff that comes in because it's just a lot. And so it's like, I'm worried it might get lost versus like if it really is targeted to make it so that it's more likely to be seen.
Oh my God, there's one challenge with trying to fulfill that request. And this goes to the heart of one of the primary questions that keeps getting asked, understandably, is when can you tell me exactly what is the answer to my specific drug? And that question cannot be answered until after CMS sets the standard Part D formulary design. And that's done every year in August. And that's a structural timing piece. There will always need to be board decisions here before CMS sets the formulary. We have to have rates done hit over. So we can't begin that communication until after CMS is done, which once you say the word September, that is the beginning of open enrollment season for some people. We can do our best to try to stagger it with words like November, but we can't get so far ahead of it and we can't be behind January either. So there is a balance there, and I definitely understand.
Yeah, like timing, but like, or if there's a way to just make it visually stand out so it looks different than, because yeah, I mean, I don't know, I worry about color coding just because not everyone can see color, but it's just that idea of there are so many, and I really appreciate it, but I don't think I'm the only one who's like, oh, another one, okay, and there goes to the recycle. Versus like trying to figure out what are the ones that are truly meaningful for me versus what are the ones that are just informing everyone.
And another piece that we could look at is if we know the exact timings, we can try to partner with some retiree organizations that I think might be on the phone right now and say, hey, can you consider putting in your newsletters? There's a mailing that's coming in the next 10 days. Be watching for things like this. But if you don't get one, also don't panic, because that means you're not impacted. But maybe there's some ways to kind of put people on alert that watch your mail closer this week.
And the retiree.
Oh, I see.
Yep.
Yeah, and the retiree organizations can also help with that,
Yep.
send out notifications. Yeah.
right, next slide. So another pretty common question we got at the town hall meetings related to step therapy and also prior authorization. So I'm happy to address those topics again here. Just to remind everybody, step therapy is when a plan requires trial of a different medication or medications prior to covering the requested medications. All plans employ step therapy as a method to ensure the most cost-effective medications are tried first, of course, including UMP. I'll note here that the Part D plan employs, Part D option employs step therapy significantly less frequently than UMP. So I want to clarify that just because a member had to go through step therapy under UMP doesn't necessarily mean they will have to go through it again under the Part D option. However, if a member demonstrates they have previously tried the step medication or medications or are unable to try them, they would be approved for the requested medication, and that same general process is used by UMP as well. Next slide. So similarly, EAs are also used by all plans, including UMP, and they ensure medications are being used effectively and direct members to the most cost-effective medication. PAs typically expire, even if you're within the same plan, after 6 months, but more commonly every year, and require renewal or continued medication coverage. Nearly all drugs that require prior authorization under the Part D plan are either not covered by UMP or also require prior authorization by UMP. Next slide. So in summary, really related to the step therapy and PA topics, Moda Health, as I previously mentioned, will continue to be the pharmacy benefit administrator. So this is good news because although drugs requiring PA or step therapy under the Part D option will require review, since it's a different plan, Moda does have access to historical UMP pharmacy claims data, which may streamline coverage decisions. And then this final bullet on this slide just relates to the transition bill all members will get, which is an automatic up to 30-day supply within the first 90 days of enrollment. Next slide. So we also received some questions about how Medicare Part D covers compounded drugs. Medicare Part D covers certain compounded drugs. However, coverage is limited to components within that compound that meet the definition of a Part D drug. So a lot of compounded drugs use something called bulk powders in the compound. Those are not covered by Medicare Part D. And an estimated 116 members may be impacted by this. However, as usual, the plan will work to find a covered alternative, and these members will also get that personalized outreach that I mentioned earlier. We also, as Ellen mentioned, received some questions related to drug copay coupons. A little bit of background about these. They're provided by drug manufacturers to reduce or eliminate a member's out-of-pocket cost I want to be clear that the health plan still pays for the remaining drug cost. So most coupons do not work unless the medication is already covered by the plan. Federal anti-kickback statute makes it a crime for manufacturers to offer drug coupons to Medicare beneficiaries. So with that being said, drug coupons cannot be used in Medicare Part B plans. So the bottom line here is that UMP retiree members currently benefiting from drug coupons would need to pay the full cost share under the Part D plan. They would not need to pay the full cost of the drug, assuming that drug is covered, just the full cost share amount. That was, I think, a little bit of a misconception that we helped answer in the town hall meetings. Next slide. So you might wonder why you can't use copay coupons in Medicare plans. And at least part of the reason for that is that it undermines the plan's ability to direct members to the most cost-effective drug. Because copay coupons reduce or eliminate the copay, this can incentivize members to use expensive brand name medications when less costly, equally effective options are available, which might contribute to higher premiums for all members. And then I'll also note here that drug coupons are not exactly a reliable method. They can be withdrawn by the manufacturer at any time as well. Next slide. So just a quick example related to drug coupons, and I'll say this is kind of like a worst case scenario. But Tony is a UMP Medicare member who uses a specialty medication to control his immunological condition. He currently uses a drug manufacturer coupon, which eliminates his monthly cost share. So he's not paying anything under UMP. However, the plan does pay the remaining cost of that drug. So under the Part D option, Tony would now be responsible for the full cost share amount, which is $90 per month for preferred specialty medications under the Part D option. Monthly premium savings, as Dave was discussing earlier, are expected to outweigh the impact of drug coupons. However, we certainly acknowledge that some members may be affected by this. The next slide is just a pretty brief timeline at this point. So the PEB board vote is scheduled to be at the next meeting on April 11th. The 2025 formulary will be finalized by the end of August this summer, and that's a CMS defined timeline. MODA customer service will be available to answer more specific questions, about that formulary in the fall. There will be a drug lookup tool similar to what UMP members have today, where they can go look up their drug and how it's covered, and what the cost share will be. Open enrollment will be around that time, and then the proposed go live is January 1st, 2025, as you all know. But that concludes my portion of the presentation. If there are no questions, I can hand it over to Dave, who I believe has the next slide. So it's actually a 5.
I was gonna say, I usually make it a quintet. Slide 23 is mine. So I just want to check in if there's any, I won't say the word final, any additional questions for Luke on pharmacy. Okay. And I will take one of the other questions that we expected y'all to ask. And in fact, a few members, retirees over the last month have asked this question. Because what we've described to everyone is something that has a lot of advantages to it. So the natural question that came up is, so why not talk about this before? And it kind of gets to that question of feeling like, oh, this is another rushed scenario. And I realized as I've been thinking about this question for a couple of months actually now. And I realized that very few people have been in the journey for the entire story, because the real story of all of this starts 8 years ago. There's only one board member who was here at that time, Harry. My entire management team has turned over since then. Tanya Dool, she's been here the whole time. Molly left, came back, but she was here for the beginning and the end. So even Ellen wasn't part of the original story. So I was like, and Lou was here 8 years ago, but he's had a lot of different roles with PEB and not been as involved with the day-to-day PEB. So there's very few people who have been here for the entire context to think about, why this would come up when it came up. And so
Before you turn it over to Harry to explain now.
well, and then Tom, I'll say Tom comes a close second.
10 years.
Yeah, Tom comes really close to having been here for the entire time, and because he started right after the first stage of this. The story really begins the historical context. I'm not going to walk through 8 years in its entirety, but just I think it is important context. Was in 2017 was the first really large premium increase. In the summer of 2017 for plan year 2018, it was around a 20% increase. I think it was my 10th day as acting director of the then PEB program when I also learned that we were going to launch SEB. And I very distinctly remember sitting in this very room with public comment generally, literally to my right, talking to the board about the premium increases that were being faced and having to answer the question to the board of, well, what can we do about this? And my answer was very clearly an answer that's very frustrating to hear and frustrating to give, which is, if the plan premium isn't authorized, then the plan ceases to exist. That's where we are. And it's a very hard message to send and a hard message to receive. And so after that meeting, it was, well, we're going to talk about, there's a long journey here. We knew in the very beginning that the retiree drug subsidy was already in a non-financial sensical state. We get asked a lot, how much more would the legislature need to invest money before we reach the break-even point? And it doesn't make sense to try to qualify for the RDS. So it's like, go back in your time machine, it was before 2010. We have already, not many people, back in 2010, we were spending $5 to make $1. And most people wouldn't do that investment. And today we spend roughly $10 to make $1 when it comes to the RDS. So pursuing the RDS has for 15 years, more than 15 years, it's never been a financial, logical question at that point. But we knew that there was going to be a point where even the RDS, we wouldn't be able to qualify for it. We didn't know when it was, but we started down a journey of talking about different ideas. And the first iteration of response was the value formulary. And the value formulary took 2 or 3 years of conversation with the board. And there were a lot of concerns about how that would be implemented, what the outreach would be, the individual member impacts. It failed the first time through the board in conversation. It failed the first vote. The second time around, it passed, but in a way that was much more contained. It had less impact on the portfolio. But the theme of that idea was minor changes to the formulary. And you've heard us say over the last couple of months, these are also minor changes to the formulary. Even five years ago, the concept of minor changes to the formulary was very hard for people to wrap their head around or support. So as we were looking at options going for the past couple of years, like, how can we go back with another formulary conversation that has similar language and had similar concerns? It didn't feel like there was going to be the acceptance or tolerance or willingness to engage in that conversation. As we've had the last 2 years, more and more premium increases. And, if you think about it, the idea in 2022's board season about, well, what if the plan closed, was really to say, it's a similar talking point to 2017 of your only choice is to pass these premiums or the plan closes. is to say, well, if these plan increases are not tolerable, let's make sure there's an orderly closure. As we all know, we've learned very clearly the importance of UMP in the portfolio. And because of that conversation in 2022 about how important UMP is, it really opened up the conversation for all sorts of ideas, including minor changes in the value formulary, which having this conversation over the last couple of months, both with retirees and the board, is very different than the value formulary conversation we had several years ago, even though at a fundamental level, they're both about minor changes in the formulary. The other thing that we have that's different than 5 years ago is MOTA and the agency implemented the value formulary, and the experience retirees had around what they were worried would happen in that change. We've been able to show how that process worked, what that outreach is like, and that some of the impacts that were concerned didn't manifest in the way that people were concerned or were afraid that it would happen. So there's that, which is another difference from a couple of years ago. Then we have the agency itself has more experience with EGWIP product, the employer group labor plan, because that is fundamentally what the United Healthcare product is. And we also have retirees we can point to that as an example of what that type of product looks like. And then the Inflation Reduction Act happened. And there are different changes that make a Part D standard plan more desirable and have more protective measures. This whole concept of Medicare drug pricing is a very valuable price protective measure for retirees that didn't exist before. Well, it doesn't exist until 2026, but even the concept of it didn't exist in federal law until the IRA passed in 2022. So there are all these different moving pieces, but at its base, one of the hardest parts about trying to think about bringing this idea to the board, to the public, and to the retiree community was the reaction and concerns that were inherent in the value formulary conversation, since some of the changes are so similar in the verbiage we use, in the conversation that we had. So it's not that this was never an idea that the agency ever considered or analyzed. It's the context of what was happening in all of the conversations with UMP, with all the stakeholders, whether that's individual retirees, the board, the legislature. The conversation as it evolved over the last 5 years is what has led us to the point to say, here, we can show all of these pieces in a brief period of time to respond to what is the real impact that so many people are worried about. It is much more disruptive for people to have to change providers and change plans in the 10 to 15,000 range every year than it is to have some minor changes of the formulary to a small part of the population, but then may help stabilize some people's ability to return to this plan or stay in this plan. So it's just that conversation. It's not that the agency hasn't been talking about this or trying to prepare or thinking about this. It's the dynamics that allowed that conversation to happen have changed over the last 7 to 8 years. And so that's the true answer to the why wasn't this talked about before. And we are working on a written FAQ to eventually publish on Ellen, it's not Ellen's website, but the website Ellen helped manage to answer this question, because it is such an important. It comes with a sense of skepticism as to like, well, this is the greatest thing since sliced bread. Why didn't we talk about it before? Well, there's a story there. There's a context there as to whether and how people would respond to it. And people, because of the last couple of years, and realizing that fundamental question back in 2017, what can we do is, well, you can either authorize the premiums or you can close the plan. That's a very hard conversation to have. Having that conversation in a different way in 2022 led us to being able to have the conversation today. And with that, I'll open up for questions.
I have one question. Well, first, I want to say the staff's done a wonderful job. You guys have brought us so far since last July, whenever we had our last meeting. And what I was sensing, I was hearing back then was this might be a 2026 thing. So I want to appreciate the fact that we're on the 2025 degree. But the question I had, and I certainly know the answer to this, I just want to kind of hear it. There's only a handful of states, groups that still do COB. And my recollection is I think there's 3 that have a Part D. So my hope is that we've reached out to those others and asked them about their lessons learned, or if they had to do it all over again, is there something they do differently, or was there some unintended consequence that came about that they wish they had thought about before they submitted, or whatever the process is. Thanks.
There's some that can always be more outreach, and So we'll keep kind of conversing on that, but to some extent, yes, you're right, there are very few states though that have experience, and even our benefit design is different than all of theirs. You know, you've seen one Medicaid program, you've seen one Medicaid program, you've seen one COV retiree program, you've seen one COV. But yes, there are inherent things that can be learned, and we absolutely work with partners, other states to try to understand that where we can.
I have a question, of course. When did you get the idea of sort of separating and creating a UMP plan Part D? When I first heard it, I thought, geez, why hasn't this come up before? You know, I didn't think of it. But when did you guys get?
So some of the original analysis after the 27 premium decreases, 2017, what year I just said, it was a potential option that was looked at. It really gained a lot more momentum or steam as we were doing the 50-state survey and seeing, oh, the only other states that have remotely most analogous things are doing this. And there were retirees who brought it up in listening sessions, and it just kept kind of coming back up in a couple of different ways. It wasn't something that was so far into the agency, it just hadn't been the piece that was truly pursued. And in part, it wasn't, so it's something that's kind of been in the background for a while, but again, that context of how things were developing and the tolerance for change and those pieces, it really just gained a lot more viability, really, as we really started the 50-state survey. That was kind of a more of a turning point for it.
And there's also,
because I've got some experience in this, and I was associated with a health state plan where I was the administrator 20 years ago. Similar situation, only 20 years, or 15 years earlier than our plan, in that the drug spend was overwhelming, and it's the same percentage then as we have now. 65% or more is prescription drugs. 35% is medical, just kind of the opposite of what it is with the active component. And so, went through the whole process. Premiums needed to go up, and frankly, saw that, but they didn't have. I left, retired, and all that stuff, but long range didn't have the expertise or the drive, if you will, or the guts to go this route. They just said, well, okay, all you retirees, supplemental plan and a Part D. And so that was the easy way out. And the retirees there, maybe more as vocal as ours are, or strong in numbers as ours are. So this notion has been around for here 15 years. But the 2017, I remember that meeting very well. And I can tell you since that time, it was always, we don't want to do anything to our plan. We like it. And so I think that was the focus on the board, was leave the medical plan alone. And in the background, I think, was some hope that this whole spending thing wouldn't keep accelerating at the same rate. And it's the hope, maybe this will be the last year. And then, of course, you get to April and May, and by then it's too late. And so it was all well intended. And I think that we really probably couldn't have done anything sooner. And now that we recognize this is the direction to go, we're putting the appropriate level of dynamics into it to make it happen. So I'll get off the soapbox. Leave it there.
I appreciate it. I think we're going to turn it over to Stella to walk through the resolutions. Or Ellen, sorry, we start with Ellen because it's a duet. Ellen and Stella, I'll just turn it over to them.
Thanks, Harry.
Go ahead, you make all your stuff come. Get set.
Takes a lot to work with me.
I think vice versa, it takes a lot to. Good afternoon, Chair McDermott, members of the board. My name is Stella, Policy and Rules Coordinator from the PEBB Division. I provided the board statutory references in the earlier presentation, so see tab 7, slides 2 and 3. So I'm not including them in this presentation. Here are the 6 proposed policy resolutions. The first resolution, PEB 2027-17, would address UMP Classic Medicare Part D coverage, and Ellen will go over this one with you. And I will address the last 5 enrollment-related resolutions. And before I turn it over to Ellen, I will go over the rest of them. So the second resolution, PEB 2024-18, would address the automatic enrollment when the Medicare enrollees who are enrolled in the UMP Classic Medicare plan did not make an election during this year's annual open enrollment. The third proposed resolution, PEB 2024-19, would address UMP Classic Medicare plan enrollment. And the fourth proposed resolution, PEB 2024-20, would address UMP Classic Medicare Part D prospective enrollment issue by addressing the gap months. The fifth proposed resolution, PEB 2024-21, would amend PEB 2022-03 Medicare Advantage prescription drug plan enrollment during the gap months. And the final proposed resolution for this board meeting, PEB 2024-22, would address when a subscriber is involuntarily terminated by a Medicare Part D plan. So the goal is to introduce these proposed resolutions to the board, get your initial insights and address any questions you may have. And we will bring the proposed resolution back to the board at the April board meeting. So I'm going to turn it over to Ellen and for her to walk you through the first proposed resolution.
Thank you, Stella. So the first proposed resolution is 2024-17. And in a similar vein to what usually happens, it's not a very descriptive discussion of the benefit because we do it at a very high level. So it just says the UMP Classic Medicare prescription drug benefit will change from creditable drug coverage to Part D Medicare drug coverage effective January 1, 2025. Next slide, please. So there are some housekeeping elements that I'd like to go over that affect how we do all the enrollment details that Stella's going to walk through. So Medicare Part D has special rules which require the applicant's signature. So like a Medicare Advantage plan, the applicant has to signify that they truly want a Part D plan. However, as an employer group waiver plan or an EGWIP, the employer group, which PEB is allowed to forego individual signatures and use, quote, auto enrollment to initially transfer the enrollees from an existing plan to a Part D plan. And members would retain appeal rights. So even if they're moved over, if they decide they don't want to do that, they would have the right to come back and question it. And the reason that we are interested in that is because operationally, it is much easier to move 30,000 people in a block than it is to get individual signatures on 30,000 forms. On this slide, I'm going to talk about enrollment disenrollment. So members who want to return to UMP Classic Medicare from another plan, or those who want to join UMP Classic Medicare initially because they've never been in it, will need to enroll during open enrollment, and they will have to affirmatively sign the form. So Form A or A-OE, the open enrollment version, includes a signature block, and that would have to be signed to be effective. To enroll in UMP Classic Medicare plan, Medicare enrollees must be enrolled in both Medicare Part A and Medicare Part B. As a condition of PEB eligibility for the Medicare plans, members have to not only be enrolled in Medicare Part A and Part B, but they have to maintain that enrollment to continue with PEB plans. And Medicare Part D plan enrollment and disenrollment requests are prospective. So just like the Medicare Advantage plans where it is future, you can sign the form today and you'll be enrolled in the next month. Part D works the same way. It has to be you sign today and you're enrolled in the next month. Disenrollment also is prospective from the date of the request. There are situations that Stella's going to talk about where we have gap months because the member unintentionally signed the form in the month that they really wanted the plan to be effective, and we cannot make that happen operation. And now I'll turn it back to Stella.
Thank you, Alan. So next slide, please. So the second proposed resolution.
Oh, I didn't read this one.
She did, Stella.
Is it?
Yeah, keep going.
Sorry.
I know what you're asking.
It's been a long meeting, it's okay.
Sorry about that. So the second proposed resolution, PEB 2024-18, addresses default enrollment for all Medicare enrollees who are enrolled in the Uniform Medical Plan Classic Medicare embedded drug coverage benefit and did not make an election. During this annual open enrollment, it will be auto-enrolled in the UMP Classic Medicare plan with an effective date January 1st, 2025. This proposed board resolution is necessary to give HCA the authority to auto-enroll all Medicare enrollees who did not make an election during the PEB annual open enrollment, so their Medicare Part D coverage will begin effective January 1st, 2025. And it reads, proposed resolution, PEB 2024-18, automatic enrollment, UMP Classic Medicare, annual open enrollment 2024. All Medicare enrollees who are enrolled in UMP Classic Medicare with credible drug coverage as of December 31st, 2024, where the subscriber did not make an election during the PEB annual open enrollment period held in 2024, will be auto-enrolled in the UMP Classic Medicare with Medicare Part D drug coverage with an effective date of January 1st, 2025. The third proposed resolution, PEB 2024-19, would require a Medicare subscriber who elects to enroll in the Uniform Medical Plan Classic Medicare plan to enroll any of the non-Medicare enrollees on the account in the UMP Classic plan. The intent of this proposed resolution is to align with how the board has adopted the enrollment requirements that address the same issue previously. This resolution will align the enrollment process the board adopted in 2020 that requires when a subscriber elects to enroll in a Medicare Advantage with prescription drug plan, the non-Medicare enrollees on the account will be enrolled in the UMP Classic. And I've placed the resolution PEB 2020-05 in the appendix for your reference. This will also align a similar process written in rules for a subscriber who selects a Medicare supplement plan. The non-Medicare enrollees are also be enrolled in the UMP Classic plan. And the proposed resolution reads, proposed resolution PEB 2024-19, UMP Classic Medicare enrollment. If a subscriber elects to enroll in the UMP Uniform Medical Plan, UMP Classic Medicare plan, any non-Medicare enrollees on the account will be enrolled in a UMP Classic.
Just to plain talk this one for everyone a little bit, this is the whole split account issue. You've heard us say over the years, split accounts. I think that's a concept many people have heard about where one person's Medicare age, one's not Medicare age, aligning with prior split account policy decisions.
Thank you, Dave. Next slide, please. The fourth. I thought there was a hand. The fourth proposed resolution, PEB. This is my trainer instinct, I'm sorry, I used to be a Shiva trainer from the Lord. So when there's a hand somewhere, I immediately, come on, I'm gonna ask the questions. The fourth proposed resolution, PEB 2024-20 would address the gap months before UMP Classic Medicare plan begins. Medicare Part D requires prospective enrollment because federal rule does not allow retroactive enrollment. Under our current rule, if a subscriber elects to enroll in a UMP Classic and Medicare Part D plan and do not submit required retiree election forms before their PEB retiree insurance coverage begins, they will have to wait till the PEB annual open enrollment or a special open enrollment to enroll in UMP Classic Medicare plan. We recommend the board to adopt this proposed policy because this will allow our retiree population to enroll in the transitional UMP coverage during the gap months before their UMP Medicare begins. This gap coverage is only used for a transition period. It is not intended for ongoing coverage. And the board adopted PEB 2022-03 Medicare Advantage prescription drug plan enrollment during gap months. And I placed that in the appendix for your reference. And I will go over that, the amendment for PEB 2022-03 in just a few minutes. And the proposed resolution PEB 2024-20 reads, proposed resolution PEB 2024-20 UMP Classic Medicare enrollment during gap months. If a subscriber elects to enroll in a uniform medical plan UMP Classic Medicare plan, and the required forms are received by the PEB program after the date the PEB retiree insurance coverage is to begin, the subscriber and their enrolled dependents will be enrolled in transitional UMP coverage during the gap months prior to when the UMP Classic Medicare plan begins. And I do have an example to illustrate this because I know this is a very complicated subject. It's been a long day for the board members to understand this policy. So I have an example on slide 33. So Joan's retirement date is July 1st, 2025. The PEB program receives her retiree election form on August 17th, 2025. So for medical, Joan selected UMP Classic Medicare Part D plan. Because Joan's enrollment in PEB retiree insurance coverage must be July 1st, 2025, consistent with her retirement date, and enrollment in the Medicare Part D plan must be prospective, there is a 2-month gap in coverage. So which plan is Joan enrolled in during the gap months? So Joan will be enrolled in the transitional UMP coverage for the months of July and August before UMP Classic Medicare Part D plan begins. Are there any questions on this one before I move on to the fifth proposed resolutions?
Just gonna add, because I know that no one asks it here, it'll be asked after the meeting, is, so what is this real transitional UMP plan? What is that, Dave, HCA? It will look and feel and be experienced like they're in UMP Classic Medicare Part D, but it can't be a Part D plan because the prospective enrollment issue. You know, we won't qualify for extra subsidies for those gap months, but they'll be charged the same premium that they'll end up being charged in the UMP Classic Medicare Part D plan. And it really is kind of this holding plan that's in place for people that, like I said, their coverage will look and feel a lot like it will come Part D. So I know it's kind of a amorphous concept for people, but it should, from the members' experience, feel very similar to what they're actually going to be and once they are in a Part D plan. and we can have some more follow-up on that if needed to clarify.
Then we're gonna have to have a resolution to approve this transitional plan?
This is the resolution to do that. We're not.
Oh, I'm sorry, big
Yeah.
part, the pricing.
There is no separate rate, so it'll be the same, thank you, it'll be the same premium for UMP Medicare with Part D.
But the look and feel will be like that, but it can't be called a Part D plan in those gap months.
So you're saying, but we won't get the subsidy? Or,
That's correct. So the subsidies that are offered through Part D coverage would not be available for claims submitted during the transitional coverage period.
you're talking about the Fed, because there are different
The federal-
subsidies
federal
floating. Thank you.
Yeah.
Thank you for clarifying that.
And to clarify further, any subsidy, so we will no longer be collecting RDS as of 2025, which we presented to the board. So these would be claims that are paid in the standard manner without any sort of claims offsets through federal subsidies.
But the enrolled retiree would still experience the state's Medicare explicit subsidy of 183 or 50%,
So
whichever.
they would still get the explicit.
Yeah, the member with the retiree enrolling would still experience the state's Medicare explicit subsidy.
That's helpful for me.
Couldn't help myself. Back to you, Stella.
Thank you, Dave. The fifth proposed resolution, PEB 2024-21, amending PEB 2022-03, MAPD plan enrollment during gap months. The board adopted PEB 2022-03 in April 2022 to address the gap months prior to when the MAPD coverage begins. Because we will be using the transitional UNP coverage during the gap months before the Medicare Advantage with prescription drug plan begins. Therefore, an amendment to PEB 2022-03 is necessary. And it reads, proposed PEB 2024-21, amending PEB 2022-03, Medicare Advantage prescription drug plan enrollment during gap months. If a subscriber elects to enroll in a Medicare Advantage prescription drug MAPD plan, and the required forms are received by the PEB program after the date the PEB retiree insurance coverage is to begin. The subscriber and their enrolled dependents will be enrolled in transitional UMP coverage during the gap months prior to when the MAPD coverage begins. Are there any questions before I move on to the final proposed resolutions? The final proposed resolution, PEB 2024-22, would address when a subscriber is involuntarily terminated by their Medicare Part D plan when enrolled in UMP Classic Medicare plan. Under federal rules, there are limited circumstances when a subscriber will be required to be disenrolled from a Medicare Part D plan because they are no longer eligible to remain enrolled in the plan. There are a couple of examples. So if someone lives outside of the plan service area, so meaning outside of the United States for over 6 months, the Medicare Part D plan must disenroll the subscriber. Another example would be if the subscriber enrolled in a Medicare Part D plan and fails to pay their Part D IRMA, which is the income-related monthly adjustment amount for the high-income earner. Then CMS will require the Part D plan to disenroll the subscriber. And the board passed resolution PEB 2023-02 last year that addresses when a subscriber is involuntarily terminated by a Medicare Advantage or Medicare Advantage with prescription drug plan. And I placed it in the appendix for your reference. And this proposed resolution reads, proposed resolution PEB 2024-22, when a subscriber is involuntarily terminated by a Medicare Part D plan. When a subscriber or their dependent must be disenrolled by a Medicare Part D plan as required by federal law. The subscriber and the enrolled dependent will be enrolled in a PEB medical plan as designated by the director or designee. The new medical plan coverage will begin the first day of the month following the date the UMP Classic Medicare plan is terminated.
And try to answer the natural question here, because I said earlier, that resolutions typically don't describe a plan name, but the real question is, so what plans are possible here? This is a really tough one because there aren't that many options. If UMP Classic is UMP Classic Medicare Part D, and United Healthcare is a Part D plan, and you're not allowed to be in a Part D plan, then the only other plans in the portfolio that currently aren't a Part D plan are Kaiser, Kaiser Medicare Advantage or Kaiser Northwest, and Primera G, which doesn't have drug coverage. And so one of those is a national plan, one of those is not a national plan. Those are kind of the choices that we have, or I guess the other choices, we would eliminate somebody's eligibility in PEB. That's a non-starter, in my opinion. It's technically a choice if you're brainstorming, but it's not an actual choice. So the choices really are in the Kaiser Primera space. And so keeping evaluating if this works for all the options, but the most likely space would be into Primera G.
So I thought you said one of the examples of when someone would be involuntarily disenrolled is if they were living outside the country for 6 months. So would then you just say, figure out whatever healthcare is available in that country, or?
So we really are working on this international problem. We have about 9 accounts that are currently international. So it is a very, very, very small number, but we're trying to figure out what exactly is the permissible plans. And in fact, we're gonna need to double check that even those international plans do actually still have enrollment in Medicare A and B and meet the threshold eligibility requirements. But more to come. This one's a lot harder to answer because of the permutations, but just describing some of the parameters we're going into it and all the more reason that we can't put a specific plan name in a resolution.
I'd like to suggest for the leadership and legal and other board members to consider that already is that maybe 24-17 could be one resolution and the other 5 could be packaged. But if you feel that you need to go through each one individually, sort of along the line of what we're going to do with the dual enrollment. Just an idea to try to economize our time. Thanks.
Yeah, we can certainly, I mean, the board can package or unpackage however they felt. We only ever crossed the package motion in dual enrollment because it was such a long conversation 5 years ago. We knew that dual enrollment, but we can package into a single motion. If that's what the board wants, we'll make the chair choose your own adventure vote for parliamentary procedure to make sure that it can be easily followed. So if you want to vote on them in a single bundle, you're welcome to, because you are right. It's very hard. They are kind of interrelated, and it's a bundle of sticks. And you can't really pull one out. They kind of go together. So we could definitely look at something like that for the board to consider for the motion practice.
Next slide, please. So the next step is the same as the previous presentation. So we will incorporate feedback from the board in the proposed policies, and then members of the public and stakeholders, they're welcome to submit feedback to HCA PEB SEB board policy feedback at hca.wa.gov by April 1st. And an email will go out to the stakeholders probably tomorrow morning, and with the proposed policy resolution, so they will have a chance to send us feedback. And we will bring the recommended proposed policy resolutions back to the board for an action at the April board meeting. And thank you very much for your time.
Questions? Thank you, group. Very nice. All right, we're on to public comment. If anyone on Zoom that would like to provide comment, raise your Zoom hand. Is there anyone on site who wants to provide comment? I think Connie and Renee ran, so they will not be providing comment. Mackenzie's working on, Mackenzie is working on the list.
We have Lori Whitener and then Fred Yancey and then Linnea Mulder.
How many do you have total?
Three.
Three total. Okay.
What's the first name?
Lori Whitener.
White hair?
Lori Whitener.
Wagner.
Wiser.
Don't you dare say white hair. No.
It's
Wiser.
Okay. Sorry about that.
We need a bit of levity. This has been a long meeting for all of you.
It has been a long meeting.
Should I begin?
Yes, ma'am, you're up.
Thank you. Okay, good afternoon, members of the Public Employees Benefits Board. My name is Lori Widener. I'm the Executive Director of the Retired Public Employees Council of Washington and the Chair of the PEB Stakeholders Medicare Coalition. As background, the coalition includes 10 labor and retiree organizations. I'm speaking today on behalf of RPEC and the coalition in enthusiastic support of the proposed new pharmacy benefit for UMP Classic Medicare. We believe this new option makes good sense and will keep this popular, comprehensive plan accessible for greater numbers of public sector retirees. We thank Dave and his team for listening to and using the information gleaned from the listening sessions and public forums held this last spring to help inform paths to greater affordability for this healthcare plan. The retirees who we helped to recruit to participate in those stakeholder engagements communicated two strong messages. First, increase the affordability of this plan. And second, ensure that Medicare options remain available to public sector retirees. Thank you for acting on these suggestions. We also thank HCA for their recent work in hosting the virtual and in-person town halls about this potential change, and for accepting the suggestions offered by the coalition to improve outreach to public sector retirees about this matter. The work that we have done together in the last year demonstrates the importance of honoring retiree voice in policy decision-making. If the board takes action to implement this change, RPEC and the coalition stand ready to work with HCA on a proactive education campaign. Thank you for listening and for giving consideration to the input that you have received from retirees. Policies can be made better when stakeholders are given opportunities to share insights from their lived experiences. Thank you.
The way we thank you for that endorsement is by butchering your name. So I, again, apologize for that. Next up,
Fred Yancey.
Fred. How you doing, sir?
Doing fine, thank you very much. I certainly second what Ms. Widener has just said, and I just wanted to add a couple thoughts. One is I just wanted to express my appreciation for the board and staff for a long meeting and a lot of preparation that went into it. Secondly, I really appreciate the fact that the ERB does personalized outreach to members that are impacted by changes. And David mentioned, there might be one or two people affected by this particular change that the agency contacts them. I think that speaks volumes about the worth of the agency and how unique it is. It's not like you only have 10 people you're serving. So I commend that, and I certainly appreciate that, particularly on behalf of those members that have been contacted. And lastly, I'll just throw in my 2 cents, and it's not even worth that. I am not a fan of step therapy. 2 years ago when the board discussed it, I think I testified as well. I understand from the cost perspective, but I have a number of friends that have had to go through step therapy, and although it sounds like, you take a pill and the next day, if it works, great. If it doesn't, then you get to try another pill. It doesn't work that way. They've had to go periods of time where very ill and no cure until, months down the line, they finally found a drug that worked. But enough said. That's just my own personal opinion on step therapy. I don't want it to water down the fact that I really appreciate the efforts the agency's been doing lately. Thank you very much.
Thank you, Fred. Next up.
Linnea Mulder.
Linnea Mulder.
Hi, my name is Linnea Mulder. I'm a member of RPEC, but I'm speaking as an individual. I'd like to thank the chairman and the members of the board for all the hard work you're doing. I have a basic question and a basic comment. On the continuity, tab 11, page 17, continuity of care, the slide says members will automatically be granted up to a 30-day supply within the first 90 days of enrollment. My question is, and this kind of ties in with what Mr. Yancey has said. My question is, if the PA process or the step therapy or tried and fail requirements take longer than 30 days, can the member continue on their previous med till approved by the new Medicare D plan, understanding that the process will probably be pretty smooth as MODA will have access to the UMP records? My second thing is a comment. I appreciate Jenny Switzer's pharmacy retail consolidation presentation this morning, along with Luke's always good presentations. I appreciate again that there will be once again another presentation regarding Navitas and MODA. And I know that Luke has reviewed this several times. Just from a really shallow online look, Navitas is owned by SSM Health, which is a Catholic nonprofit health system in the Midwest, and Costco. So they're the PBM. And then MODA, it says formerly ODS, which I think was a Argonne Dental Service, maybe, that they are a health plan. So I'm thinking that Navitas is the PBM and that MODA is the benefit administrator. But that could be wrong, even though Luke has reviewed this numerous times. So I look forward to more information about that. I think now people are generally more aware of roles of PBMs due to the press they receive currently and state and federal legislation regarding PBM. So all clarifications are welcome. Thank you.
Thank you. Dave, I assume that's for the next meeting. Okay.
Thank
Anyone
you.
else?
Sharon Etheridge.
Sharon Etheridge?
Yes, I want to let you guys know it's a lot clearer to me as a uniform medical subscriber for many years, how this really isn't a bad option. I have a couple of questions about deductible and reaching the 2,000. Can I ask that here or should I email someone?
You can ask it here. We can write it down. You can email it.
Oh,
whatever.
okay. I would, because several people I know that have it are not on this call. Is it still going to be the $100 deductible that we have with our current uniform?
There's no, Sharon, some of these questions I might not be able to answer. That one I can answer. There's no change planned for the deductible level and from today's UMP Classic Medicare to tomorrow's UMP Classic Medicare.
Okay, then I think last time I listened was maybe the retreat. And I think it was Ellen that said, you know, that we would use towards that $2,000 max, would use the cost that we pay for our prescriptions, not the full cost, to meet that 2,000, and that most of us would not even reach that in a year. Am I understanding that correctly?
That's one, Sharon, I'm gonna write down and not answer because I'm afraid I'm gonna get out of my own subject matter expertise, but we'll document that one and get back about that one.
Okay, I appreciate that. It's just a clarity. And MODA has helped me with the plan we have now. So I'm glad that they're still going to be involved in the new plan. So that's my question and comment. Thank you.
Thank you. Others? Last call. All right. Thank you so much. Our next meeting is going to be April 11th. It's going to have the same format in attendance in person or via Zoom. Dave, any comments before we head into executive session?
Just we will be bringing back Tanya will discuss the supplemental budget, and the governor will have acted on by then. Governor acts by March 30th, if I remember right. We'll bring back the 22 resolutions, some bundled, maybe some not bundled, for voting on all three of the various topics that were presented today. And then I'll just say that. So those are things we're definitely. I just want to thank everybody for a long day. We still have the executive session to go through. So let's just get onto that part of the
Those
day.
are things we're definitely doing. Okay. This part of the meeting is adjourned, and we'll go ahead and take a 5-minute break. Everybody take a moment, and then we'll come back for exec session.
And
Yes.
Tom and Kurt will still be able.
Yep, we've got the technology. All right.
So what did you think of our executive director's report? And also Linnea Moldar, RN. Nothing. Nil Luxembourg, Illinois.
We're good to go. All right, we're gonna go ahead and transition to executive session. Executive session is gonna happen here in the Crystal Room for board members and including HCA employees. At this time, members of the public joining us in person at the Healthcare Authority today, as well as employees not part of the executive session, will be escorted by staff to the lobby for the duration of our executive session. Yeah, I've been telling that language at some point. You will be you'll be called back to join us in Sioux Crystal for the remainder of the public meeting, which basically is just going to be adjournment after the executive session is concluded. So pursuant to RCW 42.30.110, 1 subsection 1L, the board will now meet in executive session to consider proprietary or confidential non-published information related to the development, acquisition, or implementation of state purchased healthcare services as provided in RCW 41.05.026. The executive session will conclude no later than 4 p.m. All right.
Now we're gonna stop recording.
And we are back from executive session. This meeting is adjourned. Thank you.